especially through the government. Since they are just informal setups, and the environment is good. They are familiar places where parents are taking these in children. So we are really excited to work in the project. Thank you so much.
Good morning. My name is Douglas Gerato. I work with NurtureFirst, supporting financial inclusion intervention, and also advising the program in Murang'a. Thank you.
Good morning. I'm Aurora Geraldine from Mombasa. Ni mama mlezi. Asante.
Greetings, everyone. I'm Mary Waidera from Murang'a. I'm the secretary at the county level, assistant secretary at the sub-county level. I'm a home-based care provider. I take care of children. Thank you.
Good morning. I'm Alice Opan. I'm an HBCC provider. At the ward level, I'm the treasurer. And at the county level, I'm equally the treasurer. Pleasure to meet you.
If you're happy and you know, clap once. No, clap once. Okay, if you're happy and you know, clap once. Nice. I'm Francis Kandeke, coordinator Women in Childcare. And I'm also a home-based childcare giver. I'm pleased to be here in this house. Kidogo is here. Tiny Totos is here. The Beauty is here. NurtureFirst is here. For us to ground the foundation of the child. I'm so passionate about this. Thank you.
Karibu sana, karibu sana.
And just to mention, where they are saying secretary, at the ward level, these are the provider networks that we have, right from the ward to the sub-county and county. So they are the leaders.
Good morning, everyone. My name is Rob Omondi. I'm with the Investments and Programs team at Imaginable Futures. And it's such a pleasure to be here, and I'm looking forward to learning and connecting. Thank you.
Karibu sana, karibu.
Mungu ni mwema kila wakati. Jina ni Mutisia Muindi, Joseph from State Department for Gender and Affirmative Action. Actually, we are in care economy. We are developing the policy for. That's one of the things that we are addressing is there is an element of child care. So you should work very hard and pray very hard that the policy is passed by the government so that you can also see or upscale your I can see mama anasema anafurahi. I think you'll be more happier when there's a policy guiding you on what is expected to do in this care economy. Thank you.
Okay, good morning. My name is Cindy, and I'm with the NurtureFirst team. I'm so happy to see all of you, so many familiar faces. Karibuni sana, and really looking forward to a great couple of hours together. Thank you.
Hello, good morning. Are you doing well today? I hope so. My name is Greg Mwendwa. I am a communication specialist. I'm helping the team at NurtureFirst to figure out the storytelling around and the narrative around the work that we're doing. So if I come to you and ask you a few questions, just know we're trying to build a good story. Thank you.
Hi, I'm Melissa Mujeni with Kidney Giving. We're a funding partner of NurtureFirst, and it's great to be here.
Good morning. It's really good to see you all. Thank you for coming on a challenging morning in Nairobi. My name is Gashari Njogu. I'm the CEO of NurtureFirst. Really pleased to have all of you. Karibuni.
Morning, everyone. My name is Dr. Monica Ogutu, a partner of NurtureFirst. I'm the Executive Director, KEMET, implementing in Kisumu County. Thank you.
Good morning, everyone. I'm the Chief of Staff at Kidogo. I'm Michael Pearson. Nice to meet all of you.
Good morning. I'm Lydia Oyugi from Zizi Afrique Foundation. Pleasure to be here to learn more about the model.
Good morning. Good morning once again. I'm Rachel Kero from the University of Nairobi Women's Economic Empowerment Hub, and I'm really happy to be here. We have been in forums and meetings with Cindy and team, and I'm so happy to be here. Thank you for the invite.
Good morning. Okwach Jared is my name. I work with NurtureFirst, supporting monitoring and evaluation. Thank you.
Good morning, everyone. I'm Debbie Otambo, working with NurtureFirst and also with the implementing partner KMET. Thank you.
Good morning, everyone. My name is Hawa Njenga. I work for NurtureFirst, and we're implementing the initiative at Mombasa County with Sauti ya Wanawake Pwani, and we advocate for women and child rights at the grassroots level to promote social change.
Good morning, everyone. Good morning. I'm Elizabeth Mwerore, supporting NurtureFirst in Murang'a County and the Catholic Diocese of Murang'a.
Thank you.
Good morning, colleagues. I'm Gati Wambura. I work for the National Council for Children's Services, State Department for Children Welfare Services. Thank you.
Thank you. Thank you very much. Thank you very, very much, all of you. I'm not seeing smiles. We are here because of the children. So I'm wondering, is it the cold and there is no cold? So what is it? Now, using the analogy from Murang'a, the providers are what? The providers are what? So who are we? Who are we? Who are we? The Pharisees. We are the disciples. So just to create a light moment for us to smile a bit, but that's a very good analogy. If the providers are Jesus, then means we are the advocates, right? We are the ones who are advocating for them, advocating for the children. So from today, we are the disciples, all right? And with that and those few remarks, thank you for everyone who is here and the introductions. I would like to invite Madam Gasheri, kindly. A clap, please, as she gets to the dais. We are excited to have you. Karibu sana, karibu.
Thank you very much. Director Mary Mbuga, Director of Children's Services, representing the PS for State Department of Children's Services. Janet Mwema and Arnold Mwanake, representing the NCC, the CEO of the National Council for Children's Services, Abdi Nur Sheikh. Wilkista Odera, the ECD Director, Kisumu County. Mr. Abdallah Mpigabao, County Community Health Strategist, representing Dr. Salma Mohammed, Director of Public Health in Mombasa, sorry. Raphael Kinyangura, I hope I pronounced that right, ECD Director, Nairobi County. Ms. Esther Mugure, Assistant Director, Children's Services. Mr. Mutisia, State Department of Gender. Our Murang'a County government partners in absentia, including the County Secretary, the County Director of Health and ECD. Valerie Akinyi, Senior Advisor ECD at the Council of Governors. Ms. Melissa Mugenyi from Echidna Giving, Rob Omondi, Imaginable Futures. Andre Kwan from UBS Optimus joining us via live stream. Felix Mutinda from the World University Services Canada, WUSC. Those are our funders and really excellent supporters. And our other partners, Dr. Monica Ogutu, the Executive Director, KMET. Ms. Violet Muthiga, the Executive Director, Sauti ya Wanawake Pwani, joining us via live stream. Ms. Faith Ndungu, Executive Director, Jeep Kenya. Father Charles Kibe from the Catholic Diocese of Muranga in absentia, but I noticed that he was represented. Members of the county working groups in all 3 counties. And I think importantly, our providers represented by Alice, Geraldine and Mary, distinguished guests, colleagues and friends. It's really my honor to welcome you all to this meeting and to share in this meeting where we will be sharing some of the findings from our mapping done last year to just understand what is the status of home-based childcare, who is providing it, who is accessing it, what are their strengths, what are their gaps, and how we can support it. I am very pleased to just introduce you now. I will not be the one taking you through the key findings, but I'm really just inviting us to actually see how having this kind of data can actually help us understand this as well as provide the support that is required. And later on, we'll also be sharing some very early results, just showing based on how we understood the providers, we designed interventions based on that data, and now we are getting early results of what the impact of those interventions. So we're really, really excited to be here. Sorry. So NurtureFirst is an organization that really is looking to enable our youngest children everywhere to receive quality care in home-based settings, and and we do this by strengthening ecosystems locally and globally, working with partners, just really to elevate the quality, so that together we can elevate the quality of home-based childcare. So across Kenya, thousands of providers, mostly women, provide daily nurturing care in home-based settings, and we have some of them here, and I think it was very, very good to just hear some of their experiences in the video, but also I think, as we continue engaging with them, we'll hear what the services look like. But in Kenya and globally, the majority of children are actually taken care of in home-based settings. I know many of us, especially in the policy space, are in a place where probably we have this privately through maybe nannies, but truly the majority of children in Kenya and globally are taken care of in community settings, in a neighbor's house, as their parents go to work. But this home-based childcare and the providers operate with limited recognition, limited support, limited even oversight and policy guidance. But this continues to be a preferred type of childcare. One, it's affordable for many of our parents. This is truly what they're able to afford. But also, too, it's what is accessible in many rural areas, but even in urban areas. I was asking myself, if I had to leave my children in a childcare, which is the one nearest to me, and I have no idea. So truly, this is the situation for many people. But also, they provide services that are, off the usual hours. We have people who work at night, so some of our providers actually work overnight. We have, people who go to work so they open very early. Some of them start even before 6. Some of them, and go until late. So they access in that way. And often they're the only viable option in low-income areas. It's convenient. It's culturally relevant. Often they speak the language, but also understand our norms, and they're trustworthy. The families trust them, and often you'll find that somebody has been taking care of a child from when they're a few months old until they transition into early learning. So we at NurtureFirst, we strengthen the systems that support these providers so that children, families, and communities thrive. And we believe that if providers are supported and we increase their capabilities, including ability to provide quality care, we support them to ensure financial sustainability of the services and their well-being, they'll be able to deliver high-quality care that improves children's outcomes. And we know that children who receive the quality of care, nurturing care they receive in the first years of their life, the youngest years, have implications for education their learning outcomes, their health outcomes, their livelihoods long term. So we believe that if they're able to provide this and they contribute towards excellent child outcomes, they meet the needs of families, including working mothers who truly have no other options. Often we think of childcare as a mother's responsibility, and some of our cultural norms do harm children in that way. But even those mothers need to work. So what do we do? So we work to support quality childcare across the nurturing care framework, which includes learning, care itself, nutrition, health and wash, and so on. We also, we support governments to ensure that they have policies that recognize home-based child providers, and actually we are working right now on, seeing how we can support both national and county governments to have a non-punitive recognition framework, because, these providers have been working, but sometimes because we haven't had or acknowledged or recognized this as a critical service, sometimes we may either not provide them services or sometimes just consider them as operating an illegal business. But also want to ensure that they're able to access government services as well as services from other, from the rest of the community. So we are supporting the connection to various organizations. Jeep talked about the work that they are doing. But we want to ensure that they're able to access services available in the community, including from the private sector. We're exploring to ensure that their work is, financially sustainable, and also while recognizing they're providing a public good, eventually seeing how can government come to contribute towards financial sustainability. And eventually you want to ensure families access quality, affordable, and appropriate childcare. So our unique, what are we, what do we do uniquely? Our goal is ensuring that the children receive this quality care. We specifically don't talk about access, increasing access, because they are accessing the services. Most of our children are going to home-based providers. How do we ensure that, when they do, they get quality of care? So we do through recognizing and mobilizing local partners, as well as a group of stakeholders to ensure this quality, safe, developmentally appropriate care is available. We partner with home-based providers. They are our most critical, partner. Shifting practice around what is care. We know that the whole ecosystem of care includes, centers, employer-based, and this. So we want to ensure that we actually shifting in terms of even how we think about this critical cadre of workers. We are designing interventions, testing what works, catalyzing investments, and working with and uplifting families and communities. At the end of the day, we recognize that this is a critical economic and social infrastructure that they are providing. It's social because it's helping children, thrive. It's helping families work. It's also an economic infrastructure because it's providing a sort of source of livelihood to providers and allowing mothers and families generally to work. So what do we do? And I will say that what we do, what NurtureFirst does, has really more or less always been done in partnership. So when I say we, it often means with partners in this room and others. We operate at a local level and globally. So we locally, like now in the case of Kenya, we collect data insights, some of which we'll be launching today, to just understand, what is the prevalence, what are the needs, what are the strengths. I think we forget that, home-based childcare is actually a strength, infrastructure that already exists. How do we support it? Profiles and priorities of providers, we map them, and also map people who can support, the providers. We working on development of county standards, and we work with, for instance, Mombasa County in partnership with our partners, including Kidogo, to help develop, sample standards. Sample is the wrong word. I think Cindy will use the right word when she comes. But really, to just, determine what should this look like in home-based settings. But also, and that journey is also ongoing right now at the national level to develop standards for home-based childcare. We design interventions and test them, and then we also advocate for policy. At a global level, we are also, setting up, with partners, we're setting up a global alliance on home-based childcare. So the fact that it's neglected in Kenya is really the same case around the world. It's still the most prevalent type of care, but there are no policies. There are not enough policies to inform the kind of work, not enough funding, not enough visibility about this kind of care. So really the alliance is going to be advancing those priorities. Sorry, I think this was all locally. Yeah, but I think I've covered all this. I think I have the slide on globally and we'll see it. So how do we see? So we see ourselves as catalyzing the ecosystem. At the beginning of our engagement, we have very high, NurtureFirst is playing a critical role, including identifying partners, working together for capacity transfer both ways. But eventually, at the end of the day, we expect that most of these responsibilities actually will be scaled through government, and through other organizations that are locally present. And that's the reason why we partner with organizations that already have a very strong presence on the ground. For instance, Sauti ya Wanawake in Mombasa, KMET in Kisumu, and the Catholic Diocese in Murang'a, because they are there and they're able to sustain the work. So this is what I was talking about at the global level. We actually looking to launch the alliance sometime next year. But really to just provide, again, same things, data to push for funding, policy, and also sharing of what works. And really, at the end of the day, what we want to do is, to have our global and local work reinforce each other. The work, truly the real work is being done in each country, in each geography. That informs the kind of advocacy and policy that we're pushing for at global level. And also what we learn at global level is also, for instance, models from other countries, etc., also inform the kind of work that we do locally. We are at an exciting, point in our journey as NurtureFirst. We actually are not very old, or maybe this is too old for the children when you think about it. So there was, we started with some study that actually showed there was a significant gap in support for people and programs, implementing home-based childcare. And so, and as well as a gap in terms of global advocacy. So NurtureFirst as an initiative was launched to try and address those, but we realized that, of course, we are not the only ones. There are many other partners who've been doing, some components of this. So we explored what the partnerships might look like. We finalized our baseline assessment last year. We've seen quite a bit of policy wins, including, for instance, in Murang'a, we helped with the ECD, childcare policy, CD policy, children's policy. As well, really, in various of the geographies, we have designed a pilot. We've been, implementing based on the findings. We've managed, I think I shouldn't say, maybe Cindy will say this, but about the getting the network started, because really believe that they want a key infrastructure, so a network of providers to continue the advocacy and peer support. Well, I came in this year. That's why I keep saying, maybe Cindy and the rest of the team. I joined a few months ago. But now next year we're looking at, going deeper, developing other interventions. We've developed something on child safety and safeguarding, but we want to develop some on the other aspects of the nurturing care framework, launch the alliance, and also explore whether some of this can be replicated in other countries. So to date, this is what we've achieved, and I want to say that we look at our work in 4 pillars. One of them is really recognizing providers. How do we ensure that they are recognized? So mapping them, characterizing them, and also, so working and getting them connected to the services available, but also supporting government towards a pathway for recognizing them in an unpunitive and an enabling way, with government not just as an enforcer, but as an enabler. So that's one of our pillars. The other one is improving quality of care. Across the nurturing care framework, so safety and safeguarding, early learning, health and WASH, nutrition, and I'm forgetting one. And then the third one is connectedness, and this is where the network comes in. How do we get them to connect for purposes of, so how do we, get the network so they can connect with each other, provide peer support, do advocacy, and we've seen some advocacy gains. I know they've been submitting county memoranda, and then finally, financial affordability and sustainability. That's the other pillar that we are working on. And so all these, across these pillars, we have things that we are doing at policy level and also at intervention level. So, for instance, one of the big ones we've been doing is quality improvement roadmaps. We design a curriculum, we train, and a lot of this is done through our implementing partners that I mentioned, and then, with on-site support, and towards improving the quality of care, and I've talked about the other two. My colleagues later on will be talking more about some of these interventions. So I've talked about the quality improvement framework. I won't go into a lot of detail because I think, Elizabeth will be talking about it later. But really, these are the pillars that we are looking to work on. We've developed the first one and we've been implementing it, but we hope to, in the coming year, to work on these other pillars, learning, nutrition and health and sanitation. We have been doing some nutrition interventions, but we expect to craft a whole broader intervention around it. So far, we've been partnering with just over 800, I think the number might be higher, providers across the 3 counties. I don't want to talk about this because about the data in terms of what they found at the beginning, because my colleagues will be talking about what they found and what we are seeing now after some months of implementation. This data, I think the numbers are higher right now. We have significant number of people registered in networks in the counties, of providers registered in the counties, and we're also implementing some financial inclusion interventions around VSLAs, training them to be able to operate their, I don't want to call it businesses, because truly they're providing a public good that we should be paying for, but to ensure that it's financially sustainable for them. I will skip over this, and I already talked about the alliance, so I'll not go into a lot of detail about this. Also, I mentioned that we're looking to, we will be exploring expansion in the close future. So that's really it about, what I wanted to just, I think it's a very high level overview of NurtureFirst. So today, the reason we are here is really to just share with you the results of the mapping that we did. We will also be talking about the role of the government in collecting this data. I think I see us as really a partner to government. So what we are doing is probably what the government is doing, we're just providing them support to do it. So the role of the government and also the key insights from our mapping, and later on we'll be launching the mapping report in the dashboard. And then beyond that, we have some early data that has come in. So first of all, we have how we use that data to inform the various interventions. And we have very preliminary results from one of our counties about the impact of that. I think the other 2 counties' data is coming in. So we will soon be sharing the more detailed results later. So the opportunity, I think for me, when I think about home-based childcare, I think it's a gift that keeps giving. It has an opportunity to actually significantly impact children's outcomes. I think last week, my background is health. I'm a doctor. I know a lot of us here at health come from learning. Actually, we come from different backgrounds, and we approach early childhood development from various angles. But last week, I was in Mombasa, and we were talking about, how we can use home-based settings to help us even achieve health outcomes. Like, for instance, WASH, minimizing, strengthening WASH systems so we don't have a lot of rotavirus, hepatitis A outbreaks. We can use them for screening for diseases like, TB. We can use this to help us identify learning and other developmental challenges early and link them to care. That's just one aspect, health. Of course, early learning, I think, is obvious, helping children be ready for preschool, but also, the livelihoods aspect and so on. But women's empowerment, mothers to work, again, talked about these livelihoods for providers, but also really thinking of this as systems change. How do we catalyze change at the government level and even at the non-government level to strengthen the systems? So I think that's it for me. Before I welcome our chief guest, I really, truly want to ask our providers to stand. I think they're the reason we are here. I think they deserve recognition. They are doing the heavy lifting. We are coming to present the data. So I think, honestly, I want to acknowledge, Mary, Alice, Geraldine. Just want to say thank you so much for the excellent work, and also for the one, I know you've left your peers at a training for the network providers, but I want to just say thank you. We really honor you for the work that you do. Thank you. And I think at this moment I want to invite Director Gatti from NCCS to come and invite our chief guest for us. Thank you.
Thank you so much. Representative to our PS, Madam Mary Mbuga, colleagues, good morning once more. It's a pleasure to stand before you, and mine is very brief. And NurtureFirst for really pulling this convening together, really to discuss a very, very pertinent issue that affects not only our caregivers, but our children as well, because we realize that how we are supporting the caregiver really directly or indirectly also affect our children. And it's our hope that the data that we are sharing here will go a long way to improve the interventions, the policies, the guidelines. She has mentioned about the childcare guidelines that are underway, really to ensure that we are supporting the caregiver as they support our children, and also providing opportunities for early learning for our children. So with those very few remarks, allow me to humbly invite the representative of our PS to kindly speak to us, Madam Mary Mbuga.
Let me stand here. Thank you so much, Madam Gatti. Dr. Gasheri Njogu, our distinguished service providers, our partners, our stakeholders. I have seen my colleagues here. Good morning, everyone. Good morning. I am truly humbled to stand before you on behalf of our Principal Secretary, Madam Karen Agengo. Should have wished to be here today with us, but she had other assignments, and she sent me to represent her. As I've stated, that I am greatly honored to stand here on behalf of our Principal Secretary and participate in this important meeting where NurtureFirst is disseminating data on home-based childcare mapping. Children are not only our greatest resource, but also the living promise of a stronger, more resilient, and prosperous nation. Childcare services play a critical role in shaping the health, learning, and overall well-being of children from birth to 8 years and even above. Quality childcare provides a supportive environment that nurtures physical, cognitive, social, and emotional development. Its importance is recognized globally and nationally, including within Kenya's legal and policy frameworks, such as the Children Act, CAP 141 of 2022, the Basic Education Act, and I should have started with the Constitution, and the Constitution of Kenya 2010, and the Integrated Early Childhood Development Framework, which I understand is under review. Effective childcare services for early childhood development plays a critical role in early identification and intervention for children facing child protection concerns and other developmental or social challenges. You all agree with me that if we would intervene at this early age or stage of a child, will actually prevent so many challenges that we are facing today and investing a lot of money in, isn't it? So this is an area that we should not ignore. This is an area now that we should pull together. Okay. This is an area now that we should actually pull together and ensure that we concentrate on this area. Because if we intervene for every child in Kenya within this age, some of our offices will close and concentrate just on this. So it is a very noble service. Kenya's childcare services for early childhood development are delivered through a range of models designed to support children from birth to 8 years and above. This includes home-based care, and I'm happy to learn that it is the most preferred. And also, if I were in the same position, I would prefer this home-based care, where children receive personalized attention in a family-like setting. We also have community-based childcare centers which offer accessible and in most cases affordable care supported by the local communities, and center-based daycares that provide structured learning and daily routine. Pre-primary school-based ECD offers formal early learning under the CBC, while employer-supported childcare assists working mothers with convenient on-site or nearby services. Additional models include the faith-based centers. We have seen almost every church has a daycare center, isn't it? And that this is something good. Mobile childcare services for nomadic communities, inclusive ECD centers supporting children with disability, and alternative family and kinship care for vulnerable children. Together, these models ensure children's holistic development through nurturing, protection, early learning, and community support. As Gasheri has stated, childcare services also empower parents, especially mothers, to participate fully in the labor market by freeing them to work, pursue education, or engage in productive activity. This, in turn, improves household income and strengthens the national economy. You can see how important that service is. Childcare services in Kenya are a devolved function under county governments, which are responsible for early childhood development and related services delivery. However, childcare provision for children aged between 0 to 4 years remains largely unregulated, and Madam Gasheri has talked about this, that this is an area that has not been given a lot of attention, even in terms of policy framework. With no comprehensive national standards or oversight framework to guide quality, safety, or operation requirements across childcare centers and home-based care services. The sector faces numerous challenges. Many families struggle with the high cost of childcare services. There are very many mothers who cannot afford even to pay 100 bob for this kind of services. Making quality services unaffordable for low-income households. Access is uneven, with rural and informal settlement experiencing a shortage of well-equipped childcare centers. The sector also remains largely unregulated, particularly for children aged 0 to 4, as I've already stated, resulting in inconsistent standards of safety, staffing, and learning environment. Limited funding also, inadequate infrastructure, and insufficient trained caregivers further undermine the quality of service, leaving many children without the support they need for optimal development. Therefore, research, studies, and comprehensive mapping, as this one that is being disseminated today, of early childhood development services are essential for strengthening the sector in Kenya. These efforts generate reliable data on the availability, quality, and gaps in the existing services, enabling evidence-based planning and policy formulation. Mapping helps identify underserved areas, assess the capacity of existing centers, and highlight disparities in access, affordability, and quality. Research also informs resource allocation, guides the development of standards, and provide insights into effective intervention. Ultimately, strong evidence-based support, more effective programming, improved service delivery, and better outcomes for young children and their families, as Madam has stated. In the Executive Order of 2025, we were done what? We were promoted from being a directorate to a state department. And as such, our mandate was expanded. Our mandate was expanded to include the regulation of childcare services, addressing a long-standing challenge in the sector. As the State Department aligns itself with this expanded mandate, several initiatives, or a few, let me say a few initiatives are currently underway to strengthen the childcare services. In collaboration with the World Bank, a study on the status of childcare services in terms of quality, access, and affordability is being undertaken. And at the same time, as Madam has also alluded, there are efforts towards having national standards for childcare services in Kenya. And she has stated something very important as I was listening. I was saying I hope my colleagues at the State Department are hearing that we should be an enabler and we should not work there to enforce. You must, you must, you must, you must. When we are coming up with standards and guidelines, let us ensure that we become enablers. Let us make it easy for people to provide these essential and very basic services at the community level. Yes, to improve and strengthen childcare services in Kenya, we must increase investment in childcare and early childhood development. I can say we are making good steps. Very soon when these studies, when we get the findings of this kind of initiatives, we shall see that even the government funding might slowly trickle in. There is need to strengthen multi-sectorial coordination from the national to the community level. That is very important. It is important to empower families and caregivers through training and community programs. It is also important that we expand the social service workforce and provide continuous professional development. It is important that we promote community vigilance and reporting of child abuse and neglect. We also need to scale up care reform efforts to ensure children grow up in nurturing family and community-based care. In fact, I've seen a lot of my colleagues and partners in the area of care reform. We are saying that the children belong to the family, so home-based care should also be strengthened. We hope that the data disseminated today will go a long way in informing policy and improving service delivery, not only in the counties that this exercise was undertaken, but across all the 47 counties in Kenya. Finally, ladies and gentlemen, children are at the heart of Kenya's future. Investing in their care, protection, and development is not only our legal obligation, it is a moral duty and a strategic imperative for national development. Thank you, and may we continue championing the rights and well-being of all children in Kenya. God bless you as you continue to undertake this very noble work. Thank you.
Thank you. Thank you very much, Madam. Another clap, please. Another clap. Another clap. We cannot champion childcare without the government, right? We cannot have an effective and long-term change without the government, right? Both at the national and? Both at the national and? Disciples, you're not discipling. Disciples from the national to the county government. And with that, I would like to invite Cindy to speak to us. We really recognize and appreciate Mombasa County government. I remember when you were collecting this data, Mombasa County government played a key role in supporting Kisumu County government. Madam Wilkista, sorry, we already did our introduction, but we could maybe say a few words as Cindy is moving forward. Thank you.
Thank you so much. Good morning. My name is Wilkista Odera, Director ECD County Government of Kisumu. I'm happy to be here.
Thank you very much. Thank you very much, Cindy.
Okay, good morning once again, and apologize for that slight technical hitch. I hope the slides are visible to people online as well. But thank you so much, Madam Director, for your remarks, and in fact, you've made my job a lot easier. I think you've preempted what I will be sharing. So first of all, before I begin to share the insights from the mapping, just want to acknowledge that this was a collaborative process. In the 3 counties that we mapped, we did not work alone, and I'll walk you through the process that we undertook. But there were key partners who were involved throughout. In Mombasa County, as we've mentioned already, the County Government of Mombasa, who will be joining me in a few moments to talk through that process. In Murang'a County, I want to recognize the Healy Foundation, who are a in this. County working group there, which was chaired by the Ministry of Internal Security and Administration and the area county commissioner there, as well as the Catholic Diocese of Murang'a and the county government who supported extremely. In Kisumu, Dr. Monica and the team at KMET were deeply involved in this process, together with the county government of Kisumu, represented here by Director Wilkes. So thank you. This was a deeply collaborative process over 12 months. This presentation will cover the 5 key insights that emerged from this data. And you will be able to complement what I am sharing with both the report, once this is launched, as well as a public dashboard where all of this information now lives for policy makers and programmers, implementers, to be able to use this data to inform effective and responsive programs to uplift and support the home-based sector. So to begin with, what did we do? We collected data from 5,400 providers who are caring for roughly 22,000 and director from gender. Why we're not in Embu? And I'd like to report that we will soon be expanding into other counties, but we focused on these 3, and these are our 3 pilot counties. In terms of then the process, what did that look like? As I mentioned, it was a collaborative, multi-phase process. We believe, to what Gacheri has mentioned earlier, the whole approach is to strengthen the local ecosystem. It's not to strengthen one actor's capabilities to map, but really to strengthen the entire ecosystem to be able to collect data, to institutionalize the ways in which data is collected, and then be able to use that data towards something. So we truly believe that data is best when it is collected collectively. And that is why we took this 12-month process. It could have been a lot faster to do it in 3 months with just one partner, but we decided we consciously opted this process. So phase 1 was really around mapping the ecosystem, co-designing the mapping itself, and then pre-piloting the tools. Part of that ecosystem mapping process we've talked about already is bringing together all the ECD actors in a room, establishing county working groups in areas where they were already established. We joined those county working groups, like in Kisumu, where we were able to identify HBCC, home-based childcare clusters, service gaps. We, in each county, mapped services that exist to home-based childcare providers, which I'll speak more about later. And then from those county working groups, we're able to identify local research teams and partners with particular strengths to help in this process, as I've mentioned them already. Those local research teams with NurtureFirst, what did we do? We determined first the appropriate sample size, which we estimated to be 25% of the provider population. We co-developed the mapping tools. We refined the methodology. So we'll speak to this a bit later, but what is a home-based childcare provider, or who is a home-based childcare provider and who is not? And how do we define that criteria? How do we know when they're active or not, if we go on a school holiday or not? So all of that criteria, that's what we did during this phase. And then the actual data verification itself. So actually doing a pre-pilot, actually, to go and identify whether these tools are working, whether our assumptions that we've made are accurate. Thereafter, we actually rolled out now the mapping. And we achieved the target of 25% of the providers in the 3 counties. And
the mapping actually comprised of both a 109-item structured questionnaire that was administered by trained enumerators, as well as a 30-item physical environment checklist. The idea is to have providers self-report what they're doing, but also be able to observe in the environment what is going on. It took roughly 1 hour to administer the survey, as well as the checklist. To complement that, we held focus group discussions with families, crucially, to really understand the demand side and to complement the data, which is included in the report. And then critically, after about 6 months, we did a verification exercise targeting 5% of the sampled population, which involved repeat interviews and observations, really to confirm whether providers are still active, whether some of the observations that were made were reliable and still being able to be monitored. And then lastly, we validated findings continuously with enumerators, and I think Abdallah will speak more to this on how that was a big learning and how that actually happened. And this was month 4 to 8. And then lastly, what we did is, and what we're continuing to do, is really translate this data into action. And that has involved sharing through various workshops, sharing with the network of providers to help them in their advocacy, where they're already writing memoranda to government and informing planning at a local level. We use the data to design 6 learning interventions as well. And we will have a panel presentation about what those are a little later in the program. So at this juncture, allow me to welcome Abdallah to come and just speak to us a little bit about how we partnered with government. What I forgot to mention earlier is that this was actually it was a staggered process, and we began in Mombasa County. So our partnership with Mombasa County government, and particularly the public health system, education system, really helped us refine the approach and repeat the same in other counties. So we're really, really grateful for that partnership, and I believe it has gone on to inform other mapping in other parts of the country. So Abdallah, can you please come?
Okay, good morning once again. Okay, for those that arrived late, I am Pigabao Abdallah. I'm here standing in for the Director Public Health, Dr. Salma. And she sent me here because I was a key player when it comes to the mapping of the HBCC. So maybe before I continue, all protocols observed. Yeah. Kiswahili tunasema itifaki zote zizingatiwe. So nimezizingatia. Okay. So before I talk about the partnership, I'll talk about an account that happened sometimes back in April 2023 in Mombasa County. During that time, I wasn't wearing this hat that I'm wearing as a community strategist. During that time, I was coordinating school health services at the sub-county level, that is Mvita sub-county. So we had an upsurge of diarrheal cases, whereby it hit most the children under the age of 5 years. So we were in that outbreak response situation. So there is a slum in Mombasa, I hope majority of us have heard about it, Chuda Moroto. Yeah, so actually I was the officer manning that ward during that time. So as a part of the response, we were majorly focused on center-based and school-based ECDs. But once we went deep into the slum areas, we found that we had HBCCs. And the partner that used to work in that space was Kidogo early years. So for us, we weren't aware of the HBCCs. Our major focus was on the center-based. So we did a lot of interventions when it comes to the center-based ECDs. But when we went into the slums, we found that actually some of the cases were coming from the HBCCs. So us as government, as and NurtureFirst, and Kidogo as a partner, for us we were enforcing, and for them there was something else that they were doing to ensure that the HBCCs are thriving. So we were like, okay, we are having these cases, we need to do these things. These mamawalezis are not regulated. They are not registered. And one of the representative came in our office, and I asked them, do you have any SOPs for you, like doing all this that you are doing? Do you have any guidelines? So it was, actually we had to use like discretion. Yeah, that this is happening when an outbreak situation. Let's look at the outbreak, other things will follow. So later on, NurtureFirst came in, and the good thing, they came, they were developing the quality guidelines. And I thought that's something that came in handy. Because for us, we were implementing the public health, the CAP 242. And for the NurtureFirst, we didn't know the guidelines that are governing all that they are doing at the community space. So I think that partnership is great. And since then, we've been working closely with Kidogo early years and NurtureFirst. So back to my presentation. So we've been working closely with NurtureFirst and Kidogo early years. When it comes to the planning of the mapping and also the developing of the quality guidelines. We've been working collaboratively within the department and also with other stakeholders that are not in the health department. In the health department, we've been working with the public health officers. That's a separate program, the community, the child health services, and nutrition. And for other stakeholders that are not within the department, we've been working with the Department of Education, the Department of Child Services, local CBOs, and also the community, the community, key community gatekeepers. We've been working together with them. So for the mapping exercise, where we did lots of consultations at the county level before engaging the sub-county teams, because the sub-county teams are quite bigger. So we had small meetings at the county level with the Kidogo, NurtureFirst, and there's some specific programs that were to spearhead the whole process. So as you can see that representation, we have I have already mentioned that. And at the community level, I think there are some, what is left out is the children's department. We also incorporated them at the sub-county level when it comes to planning all of this mapping exercise. So from the sub-county level, we went at the ward level, whereby we incorporated the public health officers that are working at the ward level, the chairs that are working at that level. We also had NurtureFirst volunteers, which help us in the mapping process. And lastly, the community health promoters. During the mapping exercise, we realized that some of the HBCC providers are community health promoters. So I think that's a strength, because with the training that we give to the community health promoters in terms of health issues, I think that's a plus. Okay, so here these are the roles, and I think I've touched on the roles. So at the county level, we did lots of mobilization, communication, and advising the steering committee. Yeah, we did that coordination at the county level, and at the sub-county levels, we had teams per sub-county. We gave them clear targets on what we're expecting from them, and this cascaded down to the ward level, which we had around 170 enumerators. Yeah, that's the public health officers, the chairs, and the NurtureFirst volunteers. Then for mobilization here, we used our community health promoters. And we felt like for our wider coverage, we need to use community health promoters. Because Mombasa as a county, we have around 2,300 community health promoters. I think for the providers that we mapped, if they were distributed as per our community health promoter, each of our community health promoter will be having like a HBCC provider attached to them. Yeah, but I understand due to like geographical distribution, you'll find there are some wards with more providers as compared to others. So this is it. And for mobilization part, actually this is where a lot of work was done. Yeah, this is where a lot of work was done. And for our community health promoters, we ensure that there is some small incentive that we were giving them for them to map this HBCC's provider. And we couldn't engage all the 2,300 community health promoters. Before the mapping exercise, we did like a pre-identification. So if you are a community health promoter and you knew that in your area there was a HBCC provider, we had shared the eligibility criteria for a community health promoter to know that this is what I'm looking for. We communicated through their community health officers, and we also shared a video. It was a short video that was made by NurtureFirst, and we shared it to them, both in Kiswahili and English. So that at any given time a community health promoter visited a HBCC, he will just reflect to that video, is this what I'm looking for? If yes, the community health promoter documents. If no, the community health promoter skips. So during pre-identification, there are some issues that arose. One of the issues, there were a lot of fear among the HBCC providers. Some felt like, okay, now the government has come for us. Yeah. Yeah. So tumepatikana, we were operating, we don't have licenses. I have a small room, 10 children, you see, things of that sort. But through our community health promoters, we sent a message that we are not doing this so that, like we shut down your HBCCs. We are doing this so that we see how you are providing your services, and if there are any gaps, we see how we can support you. So that went, actually, the first day that we started the mapping, we had a bit of little data trickling in, but after we shared that and we reassured the HBCC providers, things went on well. And another thing, once we communicated this, there is another scenario that came up. All of a sudden, everybody became a HBCC provider. Yeah, because this mapping we did it was in April towards May. So during that time we had some holidays. So during identification, you might find Mama Fulani didn't have any children, but 2 days later you find that, okay, I have children, I also do this and this and this. So those were the issues. Yeah, but using the guidelines, we told them that are you doing, how often have you been doing this, something of that sort, and that will clearly maybe make them part of what you are enumerating, or leaving them out. Okay, so maybe I'll share the key learnings and reflections. Okay, so for the achievement that we've made, something that made us achieve what we've achieved is early and collaborative planning. Yeah, this activity was set for April, but we started mapping in February. Yeah, I like to appreciate Hawa. We've like virtual meetings. After 1-2 day, a virtual meeting. But I think that's something that made us achieve what we've achieved as a county. Another thing is there was an alignment of which I've talked about the video, which ensured that we get what we want, not just getting numbers for the sake of getting numbers at the community. And there was also real-time communication. We had our WhatsApp group from the planning up to post mapping. And in that WhatsApp group, we had like everybody. We had a representative from NurtureFirst. We had representatives from Kidogo. We had a representative from the department, representatives from the Department of Education and Child Services. We all had them in one group. And during the pre-testing of the data collection tools, we also had played a very crucial role in ensuring that we achieve all this. Yeah, because there were some questions that were not clear. We felt like if you're asking this question, expecting, how will you be analyzing this data? All those, we're discussing all those in one WhatsApp group. All the updates in one WhatsApp group. The enumerators in one WhatsApp group. So each morning, the enumerators went to the ground. They all had a uniform information on what they expected to do. I've talked about multi-stakeholders collaboration, and I'll reiterate on this. We've done mapping and we've done everything, and we have a long way to go for us to achieve the objectives that we want to achieve in improving the community child care in our country. So these stakeholders shouldn't like, I won't say like during mapping we maintained it and we need to sustain it. Yeah, even after this sitting, we really need to ensure that each and every person feels like they own this whole process. Especially for the community members, if they own something, that's it. If they feel that they are left out, once the project cycle lapses, that's it. So I think that's something that we really need to incorporate in all our discussions that we're making. Let's ensure each and every stakeholder that is within our community is part and parcel of this conversation. Another key learning was the engagement of community health officers and incentivizing our community health promoters. This is something that I've talked about. And another thing is post-mapping debriefs. After the mapping exercise, we did a post-mortem. And we did it so well in such that we had the three top performers and the 3 sub-counties that had lagged behind during the mapping process. So we got to hear their feedback. And this mapping exercise also, it was a quantitative approach, but it reveals some qualitative issues that we wouldn't have thought about earlier. Like Cindy will present, and you'll see like there is some trend in some areas when it comes to the distribution of the HBCC providers. I'll give an example of Mvita. In Mvita, we had lots of HBCCs in the slum areas. But when it came to the posh areas, we couldn't find providers. And also there were some areas within Old Town. If you've come to Mombasa, Old Town, yeah, najua Old Town ukikuja lazima tukupeleke huko. Yes, yeah. Ni kama ukikuja Mombasa ni hapa Archives. Kama ujua Archives hujafika Nairobi. So if you come to Mombasa, we need to take you to Old Town. So in Old Town, we recorded a very low number of HBCC providers. And when we started interrogating, like, why are we not getting HBCC providers in Old Town? There were some cultural issues that were tied to the whole childcare practices in that community. Yeah, you find that there is a grandmother, akona mtoto wangu, mtoto wake. Yeah. So looking at the eligibility criteria of looking whether that's a HBCC or not, that's not a HBCC. We also have the issue of skip generation. The mama went to Qatar, to Dubai. Ameacha watoto kwa nyanya yake, nyanya ya watoto mwenye anawalea. So such issues. We had people that were taking care of children that are not theirs, but they were not meeting the criteria that we used when it comes to mapping of HBCCs. Yeah, so I think that's what I can share. And maybe my parting shot is, as a county government, we appreciate the collaboration that we've had with NurtureFirst Kidogo. And I know there are other partners that we've worked with, directly or indirectly. So my call is, let's strengthen this partnership and ensure that it doesn't stop here. Yeah. Our governor has there is a project that is also coming up in Mombasa, also targeting children under 5. We want to make Mombasa County to be like the best place to raise a child. Yeah. So that's the goal of our governor. Yeah. And I think through your efforts, you are contributing towards realizing that dream. Thank you.
Thank you so much. Let's appreciate Abdallah again. And our partners in Mombasa, Kidogo, who also are part of this process as well. So thank you. Okay, I will now go into the key insights, and there's 5 of them. And the data collected will be part of these five key insights. The first key insight that emerged was that home-based childcare, as we know already has been said, is really a critical care, foundational care system that is core social and economic infrastructure. A somewhat surprising finding early on as we analyzed the data was that actually home-based childcare is prevalent across both rural and urban settings. I think there's sometimes an assumption that it only exists in urban settings, but actually from the data we found that there are actually more providers in the 3 counties in rural settings than there are in urban settings, as you can see. So it might be a bit small, but the top 2 columns represent rural settings, which indicates that there is still a very strong cultural and community demand across these settings. I think Abdallah has already alluded to this, that there is a real diversity, or rather the prevalence varies across and within sub-counties. There are some areas where you'll find none. He's mentioned Old Town, Mvita, and there are others where they're too sparsely dispersed as well. Incidentally, during the mapping, the enumerators were asked to identify other forms of early childhood care and development services, and 47% of them encountered other ones. But where these alternatives did exist, they were mainly either center-based, which were nested within primary or pre-primary education facilities. They were either standalone private creches or within religious institutions. All of these options operating within a set standard hours, catering to a specific, largely middle and high income demographic of the population. And so areas where, in several areas from the dot map you can see there is both a limited supply of both home-based childcare and formal ECD centers, presenting a clear opportunity to expand and support home-based childcare in those areas as well. This supply closely actually also mirrored the demand from families, and I've skipped a slide there. So let me just go to that one. Because home-based childcare was seen and found to be mirroring the sort of economic rhythms of the counties. In rural areas in Murang'a and Kisumu, where women are engaged mainly in agriculture, casual work and small-scale trading, where there's a higher need for flexible childcare. So we find that 63% of parents who use home-based childcare are involved in manual labor, 16% are involved in informal usually market or trade-based, only 12% in office work or any sort of formal employment. Students make up a small proportion, but I think if you look within particular sub-counties and where providers were concentrated, you'll find significant numbers around university or learning institutions, which means that they're also enabling young mothers to achieve and attain higher learning. In urban and peri-urban areas where there's city wards in Mombasa and Kisumu, informal sector work is dominant, okay, and EPZ work being quite characteristic in Mombasa County as well, characterized by very long non-standard hours, day and night as well. And in these areas, we also see a high prevalence of home-based childcare, so mirroring the economic realities and the livelihood opportunities for families. So now if we just look at the children now, what did we find from the children who are looked after in home-based childcare settings? First, more than 2/3 of them are under 3 years of age. Out of the 21,784, 2/3 of them were under 3 years. Okay. In some counties, we found that 1 in 5 children actually was even under the age of 1 year. And mainly we found this in Murang'a County. So what is this telling us? It's saying that home-based childcare providers are looking after children during a very developmentally sensitive period. And in particular, when we looked at data for children aged between 1 and 3, so now not 0 to 3, but 1 and 3, they're in a particularly vulnerable period. They're in a policy blind spot in that they are out-aged, outgrown the formal health system where there is more frequent checks through immunizations and dewormings and vaccination campaigns. And they're not yet of the age where they're attaining ECD, pre-primary institutions, so between 1 and 3. And between 1 and 3, we find that a small slice of the providers that we mapped are caring for around 1 in 9 to 1 in 10 children, depending on the county that you're looking at. And so this is a particularly vulnerable cohort that is neither being touched by the health system sufficiently nor the education system. But yet they're found in huge numbers in home-based childcare settings. In Murang'a County, for example, there are 43,000 children, according to the last census, aged between 1 and 3. We found that 4,700 of those children, which is the 1 in 9, are cared for by just the small slice of providers that we were able to map, which is about 1,200, 300 providers in Murang'a County. So there is a particular blind spot here. If we now turn to the providers, and we're very fortunate to have Geraldine and Alice and why they're here also, who will speak to this later, but they are multiple and compounding social and economic vulnerabilities that are faced. 99%, as we have heard, 99% of providers are not formally registered with the government, which means that they're locked out of accessing government support services, other employment benefits and financing opportunities. 43% of providers reported that they face difficulty with rent or lease payments, and they struggle, 39% struggling with utility payments. We'll come to this in insight number 5. 49%, almost half of providers report unreliable income with difficulty collecting payments. So families are not able to consistently pay the small fee that the director also spoke to. And then 46% are actually of providers come from female-headed households. They are the sole breadwinners. So home-based childcare providers are among themselves the most socially and economically vulnerable actors in the community. And yet they bear immense responsibility for the early childhood development and future prosperity of this nation. But despite these challenges, providers reported feeling valued. 52% of providers reported feeling very respected, and 18% respected but misunderstood. So this denotes a level of social trust in the community and support for providers. Okay. Families are recognizing the vital role that providers are playing in keeping children safe, nurtured, and cared for. There's also very high job satisfaction. 75% in Kisumu, 77% in Mombasa, 86% in Murang'a report a very high job satisfaction. And so despite, there's personal fulfillment that is happening here, and which we'll hear later, in the face of multiple financial and other operational constraints. The second insight was around the need to proactively integrate providers to bridge the gap in services access. The mapping revealed a really striking gap between home-based childcare providers on one hand and the services that they have been able to access, both from government and NGOs, as well as the services that actually exist. So at the beginning of each mapping process in the counties, we map the services that exist for providers. And roughly in each county, we were able to map about 146 services that exist, both from government, health, department, education, social protection, and everything ranging from products as well, things like mattresses and potties and all of these things, 146 local service providers. But yet 3% of providers are even aware of these services and that they exist and that they could potentially access it. So there is a gap between services that exist and providers knowing about these services. Of the providers who reported access to services, 83% of them are actually receiving support or visits from community health promoters, which I think is a really fantastic finding, given also the investment that has gone into community health strategy and systems in the counties. And usually this is for vitamin A supplementation, vaccinations, deworming campaigns, and some forms of growth monitoring and developmental checks. Interestingly though, when they are being visited by the departments of the community health system, they're being visited as households and not being visited as home-based childcare providers. So there is a recognition that they're not able to access services, and there is also a very deep desire to learn and to be able to access. Particularly the graph on the left shows those who reported an interest in attending training, which is 90%, and then 3% also aware of training that exists. So there is a huge desire versus awareness gap when it comes to training, and a clear opportunity to strengthen childcare delivery and early childhood outcomes by leveraging on this interest that there is to learn. Amongst the highest areas reported by providers was nutrition, health, and safety and security. 88, 80, and 73% of providers. A particularly important area that we identified was really around the early childhood, or the early identification of special needs. About 372 children were reported to have special needs, and cared for in 2% of the providers. The graph shows that out of those 372 children with disabilities, there was 147 of those who still required special needs screening. and 95 of those had actually received some screening. Physical and mobility-related difficulties were those that were most reported, followed by development and cognitive disabilities, bearing in mind that physical disabilities are also easier to spot. And then interestingly, there was 3 times the number of providers who reported that children in their care had been screened, which means that screening is available, but it is not being targeted at the providers who are actually caring for children with special needs. So it is unevenly distributed. Okay. And early detection is critical to allow children to access the appropriate interventions at a time at which their brain is still developing and most responsive. So there is an important lever here, an opportunity to really equip home-based childcare providers to support an early identification and referral of children with disabilities or special needs in their care. So taking together these 2 insights, key takeaways, home-based childcare is a critical social and economic infrastructure. It is serving the most economically vulnerable in our society, the families, providing childcare options that are flexible and that meet their needs as they seek livelihoods. Okay. They themselves also bear a huge responsibility, even with their own, as providers, their own social and economic constraints. There is an urgent need to really shift the public perceptions around home-based childcare providers as early childhood care and educators as well, frontline early childhood caregivers, and as a core delivery for ECD services, as I've mentioned, particularly related to special needs, where early detection is so important. So NurtureFirst is working towards this by creating and supporting local community platforms. Things like the provider and services database that we will showcase later on, that has the services on one hand and has the providers organized according to needs and challenges on the other, and allowing then community mentors and networks to be able to connect providers with the services that they need, sort of last mile service extension. We are collecting and sharing data as we are now to enable others to be able to identify the gaps and fill these gaps, and then building alliances to, at a local level, regional level, and national level, global level, to be able to recognize providers as the critical workforce they are and the underpinning of our society. The third key insights are that provider networks are a powerful support mechanism that currently is not fully leveraged. Social groups are a common feature, I think, in African societies. Amongst providers, they reported that 2 in 5 providers are part of some form of social group. Usually chamas is what was most commonly reported, but 60% don't belong to any group. Again, of those, providers themselves, though, are not connected to one another. So 60% are not connected to any social group, and an even smaller number, 17% are not connected to each other. 17% are connected to each other. So the majority are not connected to other home-based childcare providers. So there is an opportunity here to create both communities of practice and communities of belonging. And I think of all the interventions that NurtureFirst has implemented over the last 2 years, I think the network is one that has really had the greatest momentum and seen the biggest impact. The numbers right now, they're quite small here, but of those that wanted to be connected, it's overwhelming. 85% in Kisumu, 87% in Murang'a, in Mombasa, and 71% of Murang'a. Related to this, 78 providers said that they do not receive any information about home-based childcare and their work that could support their work. Again, further underscoring the need to create these communities of practice. Really happy to report that the networks now have close to 1,000 that we'll hear later as when we hear about the learning interventions. We're close to 1,000. A national network has been established. The leaders are actually meeting this week. And so we're looking forward to being able to reach and extend those networks and support providers to extend those networks to all of those who've expressed an interest. So the key takeaways here is really investing in provider networks is essential to ensure the authenticity, integrity, and sustainability of home-based childcare reform. Real sort of social and political reform and change will not come from intermediaries in the room, but really the real voice and the real engine will be the providers themselves. And strong provider-led networks also surface immediate needs. Okay, they're a critical pathway as well to be able to extend services, critical services that have been identified by providers themselves through this sort of last mile extension, as well as strengthening their emotional and financial resilience. So I think providers both in Kisumu and Mombasa have also benefited from mental well-being training as well, and there's a huge demand for that, and so we're working with partners to support scale that. So how are we addressing this? As NurtureFirst, addressing the current fragmentation by supporting providers to establish and manage their own networks as well, and conceived as both communities of practice and belonging, as mentioned. The fourth insight, and quite a heavy one, is really around quality and how providers are implementing the quality, the nurturing care framework. So I think first, good to preface with how we conceive policy. I think we've heard that there isn't a national standards yet on what quality should be, or what standards should exist in home-based childcare settings. Efforts have been made in Mombasa County that Abdallah spoke to in partnership with Kidogo to define what minimum quality looks like. So what we did is we took three main approaches to defining quality. One is really understanding how families and communities view quality. So it was initially informed by the voice of the families. We did focus group discussions with families to really understand what do they want to see for their children in home-based childcare settings. Secondly, we looked at local expertise and contextualization. So the platform Mombasa, the development of the minimum quality guidelines, was a starting place as well. Those guidelines were also leveraged on existing public health regulation tools, also looked at education, quality assurance tools for pre-primary education facilities as well, and social protection standards all applied. And so we looked at all of those, drew on the most critical minimum standards that we could get from them. And then lastly, global benchmarking, which provided the external rigor and ensured alignment with evidence-based practice. And then we organized the guidelines into both, the standards into process and quality. Process and structural, sorry. Structural referring to the physical environment and the foundational features such as materials that are available to providers and children. And then process quality, which is really around how providers engage with children and the routines that they follow. And so based on that, what did we find? So with regard to physical quality, we found that home-based childcare providers meet some of the minimum physical environment conditions, but with key areas for improvement needed. 65% of providers were meeting sort of ventilation standards. 55% were meeting standards related to hazards, so the spaces were free from hazards. 55% had hand washing facilities. 40% had adequate space with decorations. 38% had secured premises. And then 25% had age-appropriate toilets. 15% accessible exits, and 15% age-appropriate furniture. We need to understand this within the broader context of what low-income housing looks like, where there's very high tenancy, there's shared facilities, shared wash facilities, and we have to consider this in the context of drainage and general infrastructure. And so when we look at some of these standards and the attainment of standards, we know that it is not out of a neglect or an unwillingness to comply, but really there are physical and infrastructure limits that have a bearing here on the attainment of some of these standards and guidelines. And lastly, without sort of national standards that also govern infrastructure and the physical environment, it also very difficult to support providers to work towards something, which, as we've heard, there are efforts underway to develop national childcare standards, building on what has also been done at the county levels. In terms of materials, which is also a critical component of physical and structural quality, 70% of providers feel they do not have access to resources for their children. And in that, we're talking about toys here, manipulatives that really support socio-emotional learning, that gross motor as well. And providers are citing this as actually their top challenge. Of those that do have access, close to 60% are using locally available materials as well. And 1 in 5 are able to purchase materials, and usually this is in urban settings. We found that more in Mombasa and Kisumu. Sorry, apologies. Books are an important tool for building children's vocabulary, imagination, attention, and early concepts. But we found that only 18% of providers report having access to books. In terms of, now if we move over to process quality or really thinking about the characteristics and the workforce and the capacity of the workforce in terms of formal ECD training and professional development, 91% of providers have never had any form of ECD training. Okay, among those who are trained, the pattern is highly fragmented. It's a mix of ECDE certificates, one-off trainings, maternal and child health sessions. So it's really, really heavily, the experience of providers really comes from their their community, their practices, and their experience caring for children over the years, and not from sort of formal ECD training that has not been currently available to them. So what we did find, though, is that providers are reliably attending to survival and health needs. The average provider-to-child ratio is 1 to 3. Which allows for each provider to closely observe each child and cultivate really secure and trusting relationships and engage in frequent one-on-one interactions, which arguably is one of the most critical levers for child development outcomes anyway. Providers in all counties report spending the majority of their time meeting these basic needs: feeding, putting children to sleep, and keeping children clean. In terms of their ability to respond to, thank you. Oh, that's better, yeah. In terms of providers feeling, being able to respond to children's cues in a timely and sensitive manner, which is a real critical indicator of responsive caregiving. Over 80% of providers feel confident or very confident in their understanding and responsiveness to children's cues, indicating a robust and very capable workforce in this critical area of process quality. And so in terms of stimulation now and early learning, providers are already delivering some foundational stimulation. The graph on the left talks of the types of activities providers report doing with children. Playing indoors, singing, storytelling being amongst the highest 3. But really it's playing and singing are the highest, 78 and 70. And this is provider initiated. On the graph on the right is what children are doing. They're playing indoors, they're singing, and this is children initiated, I should say. So they have space and they're playing indoors, they're singing, they're counting. So they're rich environments. However, providers are not able to incorporate storytelling or shared book reading. And this is something that is important for language development and early literacy. In terms of outdoor areas, actually we were somewhat surprised to see actually that a majority of providers actually have access to outdoor areas, and by that we mean spaces where the sky is visible. In terms of usage, though, we see that there is actually quite a disparity in the usage of outdoor spaces, which suggests other constraints, mainly safety concerns, and we see this a lot from respondents in Kisumu. That's the highest variance. We have 83% of providers who report access to outdoor spaces, but only in 34% of the cases that children are actually using those outdoor spaces for play. So, and it's the similar differences across all counties as well. And what are they doing outside or inside? Ball games, running, jumping, and chasing games. They're playing with some manipulatives as well and improvised play. They're spending least time on cooking and role play. at only 2% there. Okay, in terms of discipline then, providers were asked to report on what discipline approaches they use and types of behavior management practices that they employ. Options were redirect children's attention, which had the highest number of respondents. So redirecting children's attention or involving the parent. The use of timeouts was seen as the less frequently used option, followed by physical punishment. So there is a strong opportunity here to further strengthen the use of positive and developmentally appropriate strategies that really nurture children's social and emotional growth here. Okay, when it comes to nutrition, and this is the last one on quality, 78% of providers report that they provide nutrition to children in their care. And the rest largely concentrated in Murang'a, where children are brought to home-based childcare with food already. Of those that are providing meals, they're providing about 11,000 of those children are receiving the bulk of their daily nutritional intake in home-based childcare settings. That is 3 meals at 60% and 2 meals at 25%. In almost all of the cases, providers are preparing this food themselves. When you look at dietary diversity, highest is starch, rice, wheat, maize, or barley. Second is vegetables, 72%, and often there's scales, sukuma wiki, mchicha, cabbage, highly reported. And then 67% pulses, which is beans, green grams, and chickpeas. Okay. On the lower end of the scale, we see dairy and we see protein sources. But I'd note here that Kisumu and Murang'a emerge as notable outliers in 2 ways. 62% of providers in Kisumu, which is much higher than the average at 42%, report being able to offer some form of animal source protein, fish and meat. And in Murang'a, similarly, 62% of providers in Murang'a report provision of dairy, higher than average dairy as well. I think it's also important to understand that there's a wider systemic constraint around nutrition. A recent report showed that 74% of the population cannot afford sufficiently nutritious and varied diet. And this is not the home-based childcare population, it's across the country. And the findings showed that it's not due to a lack of access to nutritious and varied food, it's due to affordability as a primary barrier for dietary diversity. So this, again, we have to understand these findings within the wider context for families in this country at the minute. So, what are the key takeaways here? Providers are safeguarding children's survival and well-being, primarily. But there is an opportunity with the low provider-to-child ratio to create a strong opportunity for learning, early learning and responsive giving, and positive child development outcomes as a result of that. Government partners should invest in an integrated quality improvement package that combines standards, practical training and coaching, and then supportive non-punitive supervision, but with also targeted investments in some of the aspects of structural quality I mentioned. So the provision of materials, toys and manipulatives and books, nutrition support, and seeing what can be done around the physical environment as well. And examples include things like rugs and carpets and ensuring the space is free of hazards. So NurtureFirst is piloting quality improvement roadmaps, which we'll speak to later, which consists of they combine training curricula, mentorship, SMS and voice support that helps providers to meet minimum standards. And we'll be sharing some progress towards that and what some of the midline evaluation is saying from that program so far. Idea is also to help providers be able to self-learn towards basic and ideal standards as well. Okay, lastly, on financial sustainability in home-based childcare settings. The majority of providers, well, between 34%, I should say, to just close to 90%, depending on the county, are actually charging for their services. So first thing is that not all providers charge for services. In urban areas like Mombasa, the majority of providers, 91, are charging for services. In Kisumu is where we see the lowest number of providers who are asking and charging for their services. And we say charging, we really think of it more as a contribution, and you'll see why. It's more of a tokenistic contribution as opposed to a fee that reflects the actual cost of delivery. In terms of what providers reported in terms of daily income and daily cost, we find that in some instances, their average income is actually lower than the cost that to provide the current level of service, of childcare service, and we find that in Kisumu. In Mombasa, we see that is where there's the greatest income between cost and income, and between income and cost, the biggest difference, and so the highest surplus is seen in Mombasa, and then followed by Murang'a as well. So those figures are, in Mombasa, the daily income reported, average daily income is 396 shillings, and the average cost is 224 shillings. In Kisumu, they're making a slight loss, actually, as I mentioned. In Murang'a, the income is 284 shillings versus a cost of 106. Okay. What we find is that the more children that providers have, the more income and the more surplus that they have, but the higher the net income they have as well. But we have to remember also that because of space and other reasons as well, 87% of childcare providers are caring for 6 children and less. So effectively the amount that they can generate in contributions is capped. And so this really illustrates to us that the providers cannot rely on family contributions alone to be able to deliver optimal nurturing care. In terms of what is driving the cost that they're incurring, providers are predominantly relying, are driven by 2 main things, and that is food being the highest, amongst the top 2 cited reasons, followed by utilities. Only in one county where utilities are more expensive than food, and that's in Murang'a. Now, so if providers are reliant on the contributions of families, then it becomes particularly concerning when half of the providers are reporting that families are not able to consistently pay. When we asked how do they arrive at the fees, the contribution that they're asking for, we asked how did you arrive at that? The majority of the respondents are around agreements or negotiations. So they know what it might cost to deliver optimal care, but because of what the parents are able to afford, they ask for less. And so it's agreement, negotiation, and then how much can parents afford. Only 8% said that it's based on the actual cost, actually. And then 2% say that it's a standard flat rate, take it or leave it. And those are some of the quotes from providers that we received. If I charge higher, I will lose parents. Most of them are casual workers who earn very little. And then the second one was I calculated my expenses, but parents cannot afford more, so I had to reduce the fee. So what does this all say? Providers are delivering an essential community and public service, okay? But they're operating almost entirely at their own financial risk, with minimal, non-existent government investment or support. The sector is underfunded for even the current levels of service delivery. So providers are doing their best and stretching what they have in order to provide the current level of qualities. However, improving quality, so providing more toys, more manipulatives, nutritious and diverse diets, making modest improvements to the physical environment would need investment, both public and private at a system level. And it cannot be achieved by imposing any sort of entrepreneurial framework or financial literacy support to providers alone will not help providers be able to meet the true cost. And that is because we've already said the majority are caring for 6 children or less, and income only increases as you increase the children in your care. So it is not possible without passing on the cost to families. And families, as we know, are not able already to meet the fees that they're being requested to. So NurtureFirst is working alongside partners at the systems level, where we're defining and costing what quality childcare looks like, and then working with networks and governments to include providers in policies, plans, and budgets. At a provider level, we are supporting providers that have access to financial literacy training and then practical tools as well to help with irregular income. And then through the networks as well, establishing more stable, establishing platforms and to be able, things like table banking and other tools to be able to support the networks, be able to access more resources to support with quality improvement. So, and that is my last slide. Yes, thank you. Yeah.
Thank you very much. Another clap, another clap. So from the morning, I decided to identify myself as a male disciple. Male what? So there are also male providers. Key to this, one of the male providers in Kisumu, I really love Isaac because he stands out. He takes care of kids and he's a male provider. Male disciples, clap. Male disciples. We are forgotten. Very good. Thank you, Rob. Thank you, Rob. Thank you, man. Thank you, man. Female disciples? Thank you. We decided to call ourselves that. Thank you, Moranga, for giving us. I think I'll speak about that the whole week. Otherwise, without maybe too much ado, a long time, a break. So, tea break. Grab your tea and you please come in with your tea so that we continue. In the meantime, we'll be showing a video, part of the work that we're doing in the field. So please, the tea is outside. Just, yeah, actually 5 minutes because we are pressed for time. Tea is outside and then the washrooms are, as you go down on your left, the stairs down, the washrooms are there. Kindly. I would also like to recognize the presence of Michelle. Grab your tea and you please Michelle, hi. Welcome. So that we continue. Welcome so much. Welcome so much. Video, part of the work that we're doing in the field. So please.
I am Alice Othai, founder of Glory House Daycare, that is based in Nyalenda B, that is found in Kisumu County. Yes, most of them call me teacher. I loved taking care of children as young as I was 8 years old. It's me who took care of my siblings. And one of the children that I took care of is the one who is now taking care of the children that I am having. She has taken full responsibility of feeding them for 3 months. And this is an achievement. Anytime you take care of a child, call me teacher. This will come back to you. Because one, you're guarding the brain, you're taking good health of the child, and probably one of the children God will reward you in abundance. Is the one who is now taking First and foremost, I want to thank KMET so much for uplifting women. And this is an achievement. One, we want to treasure them so much because they have partnered with us by giving us unga for uji. Because one, you're guarding the brain. I want to thank them because I think you've seen the nature of children I'm taking care of. Most of them were not the way you see them. And each and every day, I want to thank each and every day so much. They keep on getting smarter because of the added nutrition value that we find in that. I want to treasure them so much. And we also want to thank them so much because they're also taking us through several trainings. And those trainings have prompted, especially me, I want to talk about myself. One, we were just handling children without any dressing code, but I've come to learn that when you're handling a child, we are like a school. We should dress as teachers. We are guided as teachers. So we must dress neatly as we receive the children. When we are feeding these children, we should take care of even our hair. To the children. That is what she can afford. She cannot afford money. So we do not refuse any source of money brought to us. Yes. Currently, we are not having enough playing materials. I want to believe that all home-based care, we are not equipped.
Are we ready for the next session? Are we ready? Disciples, are we ready? Yes. You have left Jesus alone. Disciples? Disciples, are we ready? Ah, cool, cool. Jesus has been left alone. Huh? He has provided more manna. So the disciples are concentrating on the manna. So we have a next session coming up, and I would like to call upon Mr. Douglas, who is our financial lead in Murang'a, and also part of our key, very important workforce, who are the POs, the project officers, who are supporting in each of the other counties. So kindly indulge me in this session as I bring in kindly come in front because of time.
Thank you so much. Good morning. It's still morning. We're going to have a very interesting session, and I promise you, as disciples, we are going also to try and make it as interesting as possible. From the things we have heard from Cindy and from Abdallah, we want to try and bring out insights that have come up from the ground. Here in Kenya, we popularly have that saying, kwa ground. You know, kwa ground. Pale ground, things may be different. So we want to bring people who have really been working on in the ground, right there at the ground, to bring us insights on various areas, and we will be concentrating on 4 key areas: nutrition, recognition, networks, and quality improvement. And to start us off in this discussion, I want to bring to you Faith Dongo. Faith Dongo is the executive director of JIP Kenya. He's been doing a lot of nutrition work in Murang'a and beyond. Please put your hands together for Faith Dongo. Faith Dongo has been helping us to implement nutrition interventions in Murang'a, and I want to welcome her to sit next to me here. Number 2, I want to bring to you Hawa Wajiro. Wajiro from Murang'a County, Monjiro, not Wanjiro. Yeah. Hawa Wajiro is our program officer from Mombasa, passionate about advocacy and taking care of the women, taking care of children. Welcome, Hawa. Put your hearts together for Hawa. You are good disciples. Number 3, I want to bring Debbie Otambo. Debbie Otambo from Kisumu, our program officer in Kisumu, working hand in hand with KMET. Please put your hands together for Debbie. Passionate about quality improvement. There she is. Number 4, I bring Elizabeth Moiruri from Murang'a. This lady coming here is very passionate about networks, and she's our program officer in Murang'a. Now, the other 3 I'm going to call here are very precious to us, and these are the providers. I don't know how we are going to bring them up here, but I want us to really, really appreciate them. They do a lot of work, and we'll be hearing from them on various aspects, how they've been, their experience, how their experience has been about. So number 1, I want to bring Mary. Mary is from Murang'a County. Now, Mary is a provider from Keharu. Keharu is the town place, the town center of Murang'a County. She's been in this field for 2 years, and she's very active in our projects. She's currently sitting as the secretary for the Murang'a East Provider Network, and also the assistant secretary of the entire county network. Thank you so much. She's been trained in QIRM, and she will be bringing insights about networks. Geraldine Oraro. I want to bring you Geraldine from Mombasa. Geraldine is a trained teacher, but because of the passion for children, she morphed and transitioned into home-based care setting, and now she takes care of children. She's very passionate about issues related to advocacy, mental wellness, and first aid, and she is our representative of providers from the county of Mombasa. Finally, I want to bring you Alice Opan. Alice Opan from Kisumu. She hails from a place called Nyalenda, and most of us, even those who have never been to Kisumu, have heard about Nyalenda. But she's in Nyalenda for beautiful things, because she's taking care of children. And she's very, very passionate about mindset shift. And she has really worked hard to cause a shift in thinking, even within government settings, and also amongst the other providers. She's also passionate about QRM, a lot of passion. She will be speaking to us later. Now, we will have this discussion, and we will begin with Jeep Kenya here, the Executive Director, Faith. And I want to ask some quick questions, and they will be responding, and I want us to pick the insights that are coming from the crowd. Faith, from the needs assessment, what key gaps did we identify, and how did they shape our intervention design in how providers were supporting children nutrition?
Thank you, Douglas. Thank you, Tim. In Murang'a, after the baseline that was done, there was a needs assessment that acknowledged the inadequate information or knowledge on nutrition. Most of the providers do not know information about the of the children, especially in terms of nutrition, 0 to 3 years. So they are not able to advise on the kind of nutrition that these children should take. They are not able to advise on the kind of food that the providers are bringing in. As we saw from the data that Cindy shared, we found that starchy food was more commonly used. So they were not able to advise why do other types of food groups that rather than the starch. So there was a lot of issues on diversity. Diversity was a major problem. Food, among the food groups that are brought, is one type, and that's why we are talking about the starch. Then in terms of affordability, most parents or they cannot be able to afford especially protein-rich foods, and so that's why at times the food choices, they'll go for easy foods that are able to prepare. Then the other thing we found on the ground is they do not have knowledge to grow even their own foods. And in Murang'a, land is also small. Majority of these providers are also living in small units, others in rented areas. And so they were not able to even grow their own food. And at times, since majority of them are also casual laborers or working manual, at times they do not have work, so they are not able to buy these protein-rich foods in terms of diversity. Then again, there was a lack of partnership. They were not known by the government. Since they are operating, we said, once the CHPs were visiting, like Abdallah said in Mombasa, they found that they thought these were just homes. They didn't know these were providers who were being able to run centers. So they did not have those partnerships, people who would guide them on the kind of food that they were supposed to have. Then the other one is they were not able to plan meals. The poor planning meals, poor planning in terms of proportion, the kind of food that the children are having, they cannot be able to give the proportion sizes. Then again, the preparation of these foods was also another major gap that was identified. And then again, to go back to the design that came up from the needs assessment that we found, there was a lot of knowledge, like you saw on the data, on over 80% were interested in knowledge on nutrition. So this gave us a design on nutrition counseling that has enabled us to train these caregivers on the nutrition bit. Then this again came up, apart from these providers, other people were involved who are parents, because we saw in Murang'a, majority of the parents bring in food. So it means the person down there preparing the food is also not aware of these types of food that they should prepare for the children. So we came up with a focus group discussion where the parents, we had some parents, and we were also able to share these gaps. And from there, we were also able to train some of the parents on nutrition counseling. We also have cooking demonstrations that came in. We are trying to prepare, to show them how to prepare meals, how to prepare meal plans, how to even cook food, like in Murang'a, things like omena. There's a myth. Others would say, like, once we prepare, they are bitter. Others would say, once we prepare, like, kana kuangalia hivi. Those are some of the comments that you'd hear from the parents. So we've brought in the nutrition team that supported us and are training in the nutrition guidance and counseling to ensure that these providers and parents can be able to prepare, can be able to plan for their meals. Another design that came up is because of the diversity. Majority, if you go to the market, majority of the parents buy like cabbage. So we introduced support of vertical gardens or innovative gardening. We know with the climate change, we've said land proportion or sizes in Murang'a is small. Lack of water, we know we supply Nairobi with water, but water is a challenge down there. So we've brought the urban farming to ensure that they're able to take care of these farms through using recycled waste materials, broken karais, cement bags, vertical gardens, to ensure they're able to have diversified foods. Another design was on the protein rich, to ensure that these children have access to dairy products. We are supporting these providers with poultry to ensure they have eggs. Then we are also supporting with livestock in dairy goats. So we were able to support them with livestock, those are dairy goats, and others rabbits, but majority went poultry and dairy goods.
Thank you so much, Faith. I want to bring Hawa on board and ask a quick question. What did the needs assessment reveal about providers' ability, Hawa, or inability to access key services from county departments and CBOs?
Okay, thank you, Douglas. So across all the 3 counties, it showed that at least 97% of the providers are not aware of some of the government support that are available for the home-based childcare providers. So there is a need for us to be able to unlock the level of awareness of services availability, both at the county government level as well as the NGOs level, so that they can be able to extend some of the critical services to the home-based childcare providers.
Thank you so much.
Yeah.
Mary, a quick one. So far, do you feel like you're being recognized? Is there an element in your work that makes you think, sasa nimeanza kutabuliwa? Please pass the microphone. If somebody helps to sort that, please.
Thank you, Douglas. For the recognition, I would say we are now recognized. We were not recognized there before. People would quote us, quote unquote, the babysitters. Like, okay, now we're very much skilled. NurtureFirst came in, has helped us with skills. We've learned about childcare safeguarding. We have learned about nutrition. We've learned about first aid. We are formally certified. We have certificates of completion. We have completed the course. We are now in a better place. We can handle the children better. Yes.
Thank you so much, Mary. I think the MC said these are the Jesuses, yeah? She's one of them. And Jesus feels recognized. I don't know how to put it better. But before I go to the next one, I want to come back to Faith, very, very briefly. Faith, are there players right there in the ground who you can identify, who have supported you and the work that we are doing, that you can quickly mention, this department, that person that have really helped us in achieving our implementation?
Yes, thank you, Douglas. Yes, there are key players that have been supporting us. One, we have the county working group in Murang'a, where all this we share, we reflect on what we are doing. The county working group consists of from the chair is the county commissioner, then we have the nutrition department, we have education, we have other NGAO, we have other civil society organizations, we have parents who are, and we have even the providers. Those are some of them. Then, again, on the nutrition bit, you're working closely with the health department, with the nutrition department, and ensuring this training. The training is done by the nutritionists. We are not going out there to hire. I'm not a nutritionist, so we work in partnership with the nutritional department. Then we have the livestock department. Because of the livestock that we are supporting these caregivers with, so we are working closely with the extension officers on agriculture and livestock because of also the kitchen gardens. Then we're also working with other organizations or partners, especially the ones we are working in care reform. Why? Because this is also a home base, it's a family setup. And so we are encouraging and we are working closely with them. We have other partners that are working with JIP who are also supporting in other services. We have even had times that we have had partners who have painted some of the centers. We have also had partners who have supported in terms of mattresses for the children. Then again, because we work closely with the State Department of Children's Services, we work closely with them and they've been very supportive. Once we are going for the trainings, they are always accompanying us, especially at the sub-county levels.
Thank you, Faith.
Thank you.
Thank you. We are so grateful for all these partners that have come on board. Let me go to Debbie. Debbie, a quick one. And now we are focusing a bit on the networks. What did the mapping tell us about how isolated or connected partners felt within their communities?
Thank you, Douglas, for that. So you find, like, from the report that has just been shared, around 75% of these HBC providers mentioned that they were not receiving any form of work-related information, meaning that they weren't aware of what they needed to do. Neither did they even know that they should be called HBC providers. So you find like this level of isolation was really limiting their ability to connect to each other. Given the fact that now they didn't know each other, that they could not connect even for peer learning. And then the beauty is that from the mapping data that was done, quite a number of them really had an interest on getting to know each other and networking, meaning that now we were having a demand and opportunity to build them together, just ensuring that they get to know each other and learn and also advocate for their needs.
A quick one. Would you say that the networks have improved providers' self-advocacy? Are they able to speak out?
Yes, indeed. Before that comes in, what we did was that we used the data to get to mobilize the HBC providers into clusters. And these clusters are from the ward level, sub-county levels, county level, and even the national level. So out of the wards, the networks now have become an intervention area for NurtureFirst. That is what we use to reach them for information. And then now with trainings on advocacy, they are now going ahead to voice their needs. For example, now, in Mombasa County, we had networks getting support from the county government. We are having networks in Kisumu County having been registered, now thinking of which leaders can they be able to reach out for in terms of resource mobilization. And then they also have a space in areas where decisions are being made. And the HBC leaders through the networks have helped shaped how HBCC is being seen by everyone else. Yeah.
Thank you so much. I bring in Geraldine. Geraldine, how are you? Acha nijaribu Kiswahili cha Mombasa sasa. Geraldine, ninajua, ninafahamu, nimejua ya kwamba ulihusika sana. I'm a good disciple, I promised. Ulihusika sana katika kule kukusanya mama lezi, kuwaweka pamoja.
Ndiyo.
Na kuwa mobilize. Kuwatafuta kwenye wako, wakuja pamoja, watengeneze kile kikundi. Na vikundi vikaanzishwa huko Mombasa. Je, kule kuhusika kwa kile kikundi, kwa ule muungano wa wamama, kumekusaidia kivipi?
Asante Douglas. Kwa majina ni Geraldine Kerubo. Mimi ni mama mlezi na nilianza hii kazi nikiwa nimetoka teaching nikaingia kulea watoto wadogo. So nilikuwa nafikiria niko peke yangu mama mlezi. Sikuwahi jua kuwa tuko wengi wenye tunalea watoto. So when NurtureFirst came in, wakafanya mapping, tukakutana in a hall ambapo hatujuani. Ni wa kijiji lakini simjui. So tukajuana, tukanetwork, ndo tukajua kumbe tushajuana, tukishajuana kumbe tunafaa tuambie serikali sisi ni wale wenye tumejificha. Tunafanya ulezi wa watoto wadogo. Tulikuwa tunaogopa sababu unaweza enda pale ukafungwa. So wakati NurtureFirst iliingia ndani ikatuambia hamtafungwa, ni kazi hii mnafanya na ni kazi nzuri, hamtafungwa. So tukajiandikisha. After kujiandikisha, I have like 8 clusters in Mombasa, they are registered. Na I have another one sub county, tunaendelea bado na registration bado. Na shukuru sana sababu NurtureFirst wamenisaidia. I went under advocacy training, imenisaidia kusungumzia wale wamama wenye hawawezi sungumza kwa niaba yao.
Tumpigie makofi pamoja na mama wengine. That is so good. I want to come to Elizabeth. Elizabeth, we will be focusing a bit on issues related to quality.
Okay.
What training gaps emerged from the mapping in terms of provider knowledge? And how do you think, or how do you feel on the ground, the program has helped us achieve milestones in creating awareness amongst providers?
Okay, thank you, Douglas. There were quite a number of issues that came up, but I would say the popular themes, we had issues around nutrition, issues around health, we had safety and security, which is the major domain that NurtureFirst has focused on this year, and being a crucial component in the, in the nurturing care framework. We've been doing trainings around the different counties in Mombasa, Kisumu, and Mombasa, and Murang'a. So our main focus was child protection and safeguarding. In these sessions, we covered different areas around the child security. And also, as these providers, as Geraldine has mentioned, they were afraid to come out. And this shows that most of them are not registered or recognized by the government. In return, they are also putting themselves in danger and I quote, as they take care of these children. So NurtureFirst came in to help them take care of themselves as they take care of these children.
Let me ask you, Elizabeth,
Yes.
do you have quick numbers of providers who have been trained? Can you
Ye-
be able to mention them off the head?
Yes. Specifically, right now in Murang'a, we have over 160 providers who have been trained on child protection and safeguarding. In Kisumu, we have 77, because we recently, I will talk about the pilot that happened in Murang'a County. We did a pilot in December 2024 to try and also establish the mode of delivery, because during the mapping, one of the things that came out, there was the literacy level of these providers. So we had to analyze what is the best mode of delivery to train these providers. And from 2024, December, some of the issues that came up was not all of them use smartphones. So we had to improvise ways of getting this information to them. We use SMS programs, as Cindy mentioned. We have an SMS program. We use visuals because the literacy level also varies across the counties. In Murang'a specifically, I would say that when the data was collected last year, 88% of the providers expressed interest in getting training, but in real sense, only 1% has ever received training from either the government or non-government. Yeah.
Thank you so much. I want to go to Alice. Alice, you are very passionate about mindset shifts in relation to HBCC, and you are also key in issues related to advocacy and quality. Through this training, the QIRM, would you say you are better placed now as a caregiver to offer quality service to children, or what would you say?
Thank you so much, Douglas. First and foremost, we want to thank NurtureFirst so much. They found us in a space that we were just handling children without any knowledge. And that one, truth be told. They took us to several trainings. One that I think really motivated each and everyone, that most of us were just receiving even babies who are asleep, which was very, very dangerous. These days, you cannot come to a space with a sleeping baby. This baby has to be woken up. Another thing that we really love, that we've learned, that we are now at least qualified. There are things that can happen in your space. We do not need fire extinguishers to put off things like fire. We have sand. And strictly you must have sand in your space so that if anything crops up, you're safe to put it off. These days, we are privileged equally to an extent that we've been given tags. Parents are so busy, and we are monitoring these children. We have to know their days of going to clinics. You put on your tag, you go to the clinic, and the children are given the vaccines, which we really appreciate, so that we need to know that these children actually grow holistically. Another thing that we really want to thank the trainings for is that we've been entitled to these children for the first 1,000 days, which are very, very crucial. And if we do not guard them well, we will not produce good products going to school. So we are very grateful because quality has really improved in our spaces. Thank you.
Thank you so much, Bakofi. I would want to return to Hawa for just one more question. Hawa, give us examples. What successful examples can you be able to highlight where now providers are accessing services they were not previously accessing?
Maybe I'll share one. And in terms of recognition and the services, there are 2 levels to it. There is one that entails the formal registration through the county departments, which is still work in progress. And then the second type of recognition for the providers, it's in terms of access to some of the supportive services. And one of the success stories is we did a Malezi Bora campaign in Mombasa County, and we were able to reach 60 providers, and in total we were able to administer the vitamin A supplementation as well as dewormers to 447 children. So that is really amazing, because we also had to ensure that we provide the integrated services to the providers, such as the vitamin A supplementation and the dewormers, just to support the complete, or rather whole development of children under the age of 5.
Thank you so much. This is our battalion on the ground. A big applause to them. I want us to allow Jared to come. He will wrap it up and he will give us early learnings that are coming from the ground. I don't want these people to move away, but I want them to step aside, just aside, so that we can, I know Jared will want to do a presentation. So you are part of Jared's presentation. So I want you to step aside right there, probably with your chair, just sit. And then Jared comes and gives us early learnings and implications of everything that you have heard from the team on the ground. Some of you can sit even on this side. You are part of what Jared is presenting, so. And one more time, a big applause for the panelists. I think they have given a good account and they have given beautiful insights. Let's give it up now for Jared.
Okay, thank you very much. Mine is just to give some preliminary results of what we have as far as quality improvement is concerned. As Elizabeth had indicated earlier, we've rolled out quality improvement roadmap trainings across all the 3 counties. And because of that, when we started the process, we did some pre-assessment for providers who were selected. Later on, they were trained. We did some mentorship. And then eventually did post-assessment. Currently, we have some data streaming from the field, and I wanted to just show some few slides, and then we get back to our panelists. Okay. As Cindy had indicated earlier, from the mapping results, we are able to see that at least 45% of the providers in the 3 counties lacked training and professional development opportunities. We're also aware that 92% of the providers indicated that they wanted to attend specific types of training. When we went further and asked them in terms of their preferences, you can see the top 3: nutrition, health, and safety. And having consulted with the county working groups in the 3 counties, we realized that it was really important for us to prioritize safety and security as a training as we plan for the other remaining domains. And what I'm going to present here is just some summary from Kisumu County. The other 2 counties are still collecting the post-assessment data, but we have Kisumu County post-assessment data for the quality improvement roadmap training. And the analysis is summarized in 3 processes, 3 sections. One is the process. We were asking providers about how they have adapted the new processes and procedures. Some of the procedures we are looking at is how they have adapted signing of agreements with parents, looking at safeguarding policies, and also even trying to ensure that they have written records from the parents. The other bit was about the structure, where we are looking at the safety and equipment, more of infrastructural issues, looking at the layout of their dwellings to eliminate or maybe mitigate some safety risks. And then the third summary is on knowledge. We just wanted to understand, after training and mentorship, which took 4 months, are providers able to identify important safety risks, and more importantly, be able to take some action. From these preliminary results from Kisumu, Kisumu trained 77 providers on quality improvement roadmaps. And the results here we have for 60 providers, and it's more about comparative analysis from pre-assessment and post-assessment, where there was a difference of 4 months. You can see that there's a big sharp increase on providers who now have signed agreements with parents. Initially, only 8% of providers had signed agreements with parents to just understand how the providers will be able to take care of their children, and even issues concerning payment. We also look at the safeguarding policy. Majority of providers at around 80% are now able to indicate what are their safety policies within their dwellings. And then lastly, 91% of the providers in Kisumu now are able to have to maintain written records. Record keeping is a very key practice, and we're able to hear about providers indicating that they are now able to take some of the children to clinic, ensure that they don't miss their vaccination. On structure, it was also really interesting. Alice talked about safety, whereby now majority of providers are able to have fire safety equipment. And here some of them talk about the sand. There was a big jump, which is a 70% jump, confirming that technical knowledge during training translated into low-cost, high-impact investment, either purchasing a sand bucket or even extinguisher. It is also quite interesting to see that other safety issues have remained quite high. Providers ensuring that they have taken care of internal environment where it's free of hazards. They have also ensured that there is no open water containers to just ensure that chances of children drowning are minimized, and also ensure that the environment doesn't have small objects, to ensure that children can also limit the chances of getting choked. It's also really important for me to also mention that the expectation is at the point of pre-assessment, majority of providers were able to identify some safety issues and awareness, but then we just want to ensure that most of them are able to score 100% in terms of not only identifying but also implementing. The last bit is about the knowledge, and on knowledge, really interesting. We had questions whereby we were assessing providers about how they can identify the several types of abuse. And it's really interesting to see from this cohort of 60. At the pre-assessment, 86% of them were able to identify the various types of abuse. And then post-assessment, all of them are now able to identify abuse cases, which is a very big plus, and it means that now they are able not only to identify, but also know where to report to it. Whereby we realize that providers have now increased official escalation procedures by 18%, especially when children are not picked up. They know where to report. Is it the police? Is it the child officer? They've also increased their official reporting on suspicions of abuse. They know also where to report. Around 6% increase, which is a very increase. Then lastly is about confidence boost. At the start of the training pre-assessment, we were able to ask providers about the topics they are interested, if they were to be trained. They listed several topics ranging from nutrition, health, early learning, but of key interest was the child protection and safeguarding. Initially, 75% of them indicated that they wanted to be trained on child protection and safeguarding. However, the post-assessment, 31% of them have now reported, meaning there's a drop of 43%. And the obvious reason is because this domain concentrated on child protection and safeguarding, and it means that majority of them are now no longer having that as a high demand. So after this, what are we going to do? Considering that what I've just shared is just preliminary results, which is coming in, the latest data was collected as late as yesterday from Mombasa. So we'll want to go ahead and analyze the post-assessment data in both Murang'a and Mombasa counties, which are remaining. Go ahead and do some analysis, present some midline evaluation early next year, the first quarter of next year. and more importantly, eventually plan for end-line evaluation after 6 months. There was a clear schedule whereby we trained them. After 6 months, we did a post-assessment. After 4 months, we did post-assessment. Then after 6 months, we'll want to go back and do an end-line evaluation and be able to document trajectory of the change. The next thing we also want to pick from the learnings is refine the curriculum to include some medium and best practices that we've gotten from the initial learnings. And then more importantly, the future plans. Because this was only the first quality improvement roadmap training we rolled out, remember initially I indicated some of the preferences the providers indicated. As NurtureFirst and partners, we are planning to launch new QRMs depending on the availability of resources. And the preference during the post-assessment has been, why don't we consider social emotional learning development in 2026, and also consider launching health and sanitation or even nutrition in 2027. Hopefully all the partners who are here will be able to support us in ensuring that we can be able to roll out the remaining QRM for the providers. Thank you very much.
Thank you very much, Jared. So in the interest of time, we are going to the next step where we are having partner remarks. We have realized because of time. Can we give them a clap? Two things as I call on Rob to give us a few remarks. Two things I've heard so far. One person has told me, I didn't know NurtureFirst has other staff. So NurtureFirst staff are many. So, so that is one. Number two, as I got to introduce myself. So somebody asked me, and you're speaking, but you don't know your name. My name is Dan Ouko. I do financial inclusion, supporting both Kisumu, Murang'a, and Mombasa. Otherwise, Rob, karibu sana.
Thank you so much. My name is Rob Omondi. I'm in the programs and investments team at Imaginable Futures, supporting our partners across Kenya, partners like NurtureFirst. And I just have to admit, it was very inspirational hearing the voice of the caregivers. Can we please give them a round of applause? They're indeed the connective tissue that is making this work even more and more important. And it was so wonderful seeing them speak with a lot of passion. And this can only just mean that this work is headed in a very great direction. And just for the caregivers, for the care providers, I just want to encourage you to keep pushing. We are watching and we are supporting all your efforts, and we don't take them for granted. And also shout out to NurtureFirst, the team. You've done such a great job. We started supporting NurtureFirst, I think, 2 years ago when it was just a concept. So just being able to see staff members, the team has grown, but then also the impact of the work you're doing is also growing. So a round of applause to yourselves as well. I didn't have much to say. I was just here to learn, and I've gathered what I needed to gather, and thank you so much.
Thank you, Rob. We really appreciate your support.
So, a disciple is not introducing me. No, it's okay.
Jesus knows everyone.
Okay.
So
okay. No, thank you so much. Can you hear me? Great. I'm from Echidna Giving, and I mentioned that we're a funding partner of NurtureFirst. Why are we partnering with NurtureFirst? First, we are focused on advancing girls' education. And so the gender piece is very critical to what we do. And that doesn't focus just on girls, but it focuses on women. Of course, we know that a majority of caregivers and providers are women. It was really interesting to see some of the statistics around kind of some of the compounding gender dynamics and dimensions that providers face, such as a good number are coming from single households where they are the only breadwinner. So what does that mean? So those two dimensions of advancing girls' education and empowering women are core to what we do. When we look at childcare, home-based childcare is the most popular form of childcare. We saw the data, we can't refute it, particularly for marginalized children. So it is an anchor of the childcare sector, which is why we are very strongly backing the work of NurtureFirst and others in the sector. NurtureFirst is very modest. So allow me to toot your horn for you. In just 1 year, NurtureFirst has delivered quality improvement training to about 1,000 HBCCs providers. Is that correct? Yes, okay. The same number of providers are now part of organized networks. And as we've learned, these networks are so critical, not just from a social cohesion perspective. I think one of the providers outlined the feeling of isolation, but also from an advocacy perspective. So looking at these networks and the establishment of a national association, that is incredibly powerful. It reminds me of what's happening in Tanzania. In Tanzania, a daycare association was recently established called Uviwada, and it brings together all of the daycare providers in Dar es Salaam. And this has been such an impactful advancement because the government has now instructed all daycare centers to streamline their asks, their needs, their engagement with government through this association, because the government just doesn't have capacity to engage with each provider one-on-one. So this really has the potential not just to amplify recognition of you as providers at the individual or group level, but as a group, as a national group. We've heard about the county level partnerships. I would love to speak a little bit and toot your horn again around the national level. Some of the national level work of NurtureFirst deserves amplification. For instance, they are partnering with government, with Global Schools Forum, who is in the room, with the ECD network to develop minimum quality standards for childcare. That is huge. They've also successfully advocated for HBCC recognition in the draft National Children's Policy. Again, that's huge, because if we don't recognize HBCC as a subsector of childcare, meaningless. If we can't capture that at the highest levels of policy, then everything we're doing is anchored in nothing. We've spent a lot of time discussing the what on what you're doing, the data, etc. But I'd like to just spend 1 minute discussing the how. And I think it's really critical. NurtureFirst is not looking to be a permanent player, but to catalyze collaborations and coalitions. Why? From my understanding, it's because you recognize that sustainability requires the ecosystem with established actors, local players, to anchor meaningful change. And that's powerful. So NurtureFirst knows that its voice is not the most important voice in the room. In fact, it's the least important voice. And is taking a backbone, backseat type of approach. NurtureFirst has a global remit and is starting in Kenya. And that's excellent, because for too long, in development, models from the global north or the west have been transposed here. But now we are seeing what NurtureFirst is achieving with everyone in this room with a DNA that is Kenyan, which means whatever is done out there will kind of have our DNA, and we're going to claim that. And that's very powerful. The world needs more. The world needs more south to north learning and south to south. And then finally, the reason we're here today, which is data. We've heard that the government, in collaboration with NurtureFirst and NurtureFirst partners in this room, have started from the point of understanding the HBCC landscape through evidence and data, and critically, what our providers' needs. This, together with your collaborative coalition approach, in my view, is probably the single most determinant or strongest factor that will influence your success as a group and as a sector. Because if we begin from a point of accurate data around what the current status quo is and what the needs are, it means policies speak to real needs and systemic needs. It means resources across the board from government, from development partners are easier to unlock at higher levels if we're coming from a point of data and evidence. The ecosystem as a whole is thriving. Why? Because the ecosystem is more informed and has a collective shared sense of what are the needs and what needs to be done. And critically, providers have the right skills, the right support systems to promote improved development outcomes for children and also gain a sense of satisfaction and economic empowerment. So we are so excited to be here. Congratulations, NurtureFirst, partners, and critically, providers and government. Asante.
Thank you so much, Melissa. And now to the next partner, Dr. Monica from KMET. Karibu sana. I decided to introduce you because the other time I was told I'm forgetting some disciples. So,
thank you so much, Dan. I was actually waiting for you not to introduce me. Yeah, let me just speak after the previous speaker and pick it from there, that NurtureFirst has done a great job. Yeah, for us at KMET has been implementing the Smart Start initiative. That is the nurturing care for early childhood development. We started way back in 2018, modeled it in Siaya County, and now we are scaling it up in the entire Lake Region economic block, the 14 counties. And we intentionally took the phased approach. 3 counties, 2 counties, we are now at the 11th county. And I'm seeing nurturing care also taking that phased approach. What I love most is that it actually bridged the missing link. Because when we started implementing nurturing care for early childhood development, famously known as the Smart Start initiative, journeying with the baby from the utero, from conception, ensuring that that baby is delivered well, scores well. I hope you all know that a baby also scores at birth. Some parents don't know, and the service providers need to know that there is always a score at birth. So when a baby is brought to you and maybe scored 3 out of 10, you need to know that from the parent, because you'll be dealing with a special baby. I'm saying there was a missing link because we journeyed with this baby from the uterus, maternity units, we trained the midwives to ensure that that score is good. At least 7 and above is a good score. And please, everybody in the room, this is a message to all of us. Go back to your baby and mother and baby booklet and check what your baby scored at birth. Don't wait until too late and you want to push this baby to the academy. It's too late. It's the first 1,000 days. The brain develops during that time. So if it didn't develop, even if you take to the best academy, you'll not do anything. So the missing link was now the care centers, because we had the responsive caregiving, but at the household level. Actually, for a long time, I didn't know we had home-based care centers in Kisumu. And during the assessment, we realized we had over 1,000. In Kisumu alone, we had 1,700, I think, and 50 HBCC centers, informal. Nobody knew about them, and the first time they were running away. And even the ladies who are really taking, the caretakers that are speaking here so proudly, they were running away. So when we actually met NurtureCare, I first met Dan in Kisumu, and I went very fast to introduce Dan to the LREB Secretariat because we thought there was that missing link in the Smart Start initiative. And we started the journey. Cindy and the team, thank you for being patient with us because sometimes we thought, oh, it's already there at the household. Do we really need to go to these unregistered informal centers? But today we are proud to say that the Kisumu model, and thank you the county government representative, because what we do, how we work is county driven, community owned, but county driven, and LREB led. Because the Lake Region Economic Bloc and the counties need to appreciate all these best practices, to include them in the policies, include them in the CIDP. If they are not in the CIDP, even if we talk of funding, they'll be referring back to the CIDP. It's like the Bible in the county. So we need to document this model. My ask is to document, publish, and have a model that you can use as a tool to advocate for leaders to understand. Because our leaders invest so much in the ECD classrooms. But they don't know this software that we are talking about here. They know the hardware. So we need to do a lot of education. I've had meetings with the governors. My last meeting was in Mombasa. I had all the 14 governors led by Governor Anyang' Nyong'o. And we were talking about the science of ECD. And they were there silent, really taking notes, not with their PAs, but alone. And by the time we ended, we had a communique, a commitment. And as LREB leadership, they said nurturing care for early childhood development, including home-based care centers, is a priority. So that commitment is what we need. But you can only do it if you document this best practice. We need to also standardize reporting tools. We need to have standards that can cut across from Mombasa, Murang'a, and Kisumu. What is the package that we are talking about? That if you go to this center, that center, you'll get the same. Governor Lusaka asked the same thing. What is the package? So going forward, count on our commitment, and my priority is publication. Thank you.
So the next, we have Alejandro Kwan from UBS Optimus. We'll be speaking online. Is it set up? Welcome if you can hear us.
Dave is here. No. Okay, my cost. Change host. Okay. Yeah, just 1 minute.
No worries.
Yeah, that'll take 1, 2. Try and speak up. Let me see if I can hear you on this one. 1, 2.
Hi. Yep, testing.
You can hear it? Okay. Shall we? Yeah. Okay. Yeah, let's go in the interest of time, but you probably have to speak a bit louder so everybody can hear.
Okay. Hi, everybody. My name is Andre Kwan, and I'm a program director from UBS Optimus Foundation. It's really a shame that I can't be in the same room with you, and I do apologize for the trouble of this, hybrid approach. But thank you so much for the invitation to at least speak a little bit, albeit virtually. On behalf of UBS Optimus Foundation, thank you to NurtureFirst and all who are driving childcare forward in Kenya and beyond. Our support at UBS Optimus Foundation really comes from a simple truth. We believe that it takes a village to raise a child, but for millions, that village, those links to care, education, health, and opportunity is broken. We believe that NurtureFirst is fixing that. They're building ecosystems, working with government and local partners to reach the most marginalized. And for us, supporting kids means supporting adults. So our partnership expands affordable childcare, creates decent jobs, and strengthens families. This really isn't just about education, it's about resilience. Linking families to services reduces vulnerability and builds social and emotional strength, and we back it with evidence and impact. Just look at the numbers. 5,000 plus home-based providers caring for 22,000 children. That's evidence in action. By sharing data, they help other stakeholders such as policymakers and funders design solutions that work. By supporting NurtureFirst, we're hoping that we are investing in a model that scales. Local data, community solutions, cross-sector collaboration. This is how early childhood care transforms. We believe that it's a blueprint for inclusive growth. So let's keep building bridges between evidence and action, between families and opportunity, and together we can make sure that every child thrives. So just a quick note to thank everybody for your commitment and for your vision for a more just and resilient future. So thank you.
Back to you, Dan.
Ladies and gentlemen, another clap. Disciples, a clap. It feels like the disciples resonates with so many people, right? So I would request that we have come to the moment of reckoning, the moment of the launch of this particular report. So those who have their laptops open it at your own risk, because we might jump on top of the tables, shout, so kindly put them aside. We don't want to cause any damage. You know the way we go to a parking and see parking at owner's risk. Park your laptop at your own risk, because we might be jumping and shouting and celebrating this particular moment. Ladies and gentlemen, you've reached a particular time when we want to now talk about the document, see the document, touch the document, have conversations with the document. Our online team also be on standby for this particular moment. I'd like to call upon our CEO, Madam Gashari, please come in front. A clap for her, please. Madam Melissa, Disciple 001. Welcome. Rob has left already. He's still in the room. Madam Wilkista, please come in front. Abdallah from Mombasa County. I really loved your presentation, Abdallah. It shows how the county government has really took time to understand our model and be part of the process. Thank you so much. Madam Monica, please come in front. Dr. Gatti, please, from NCCS, kindly. Kidogo, we said NurtureFirst is a collaborator. So kindly, can we have Kidogo come forward? Can we have Esther Mugure from State Department, Cindy, of course, for the great work that you have done within the past year. Please come in front. Who am I forgetting? CDM, please, Madam CEO, karibu hapa mbele. Stahili, please, Michelle, come in front. You guys have been there for with us during the whole process. Our POs, kindly, our POs, they have been our frontline foot soldiers, our frontline staff, the conversations that are going on in the field. I really appreciate. Can we clap for these the POs, our frontline staff who support part of this work? So to also join us in front. Yeah, oh, oh man, why am I forgetting? Jesus representatives. Karibuni, sorry. Oh, Mr. Mutisia from the Children's Department, kindly. It's gender, sorry. That shows you the disciple is thinking about manner and is kind of forgetting some of the people. Oh, happy to hear that. Nasikia mtu anasema umejiona mahali. Madam Alice is one of the providers, and just to mention her critically, when you were having discussions in Kisumu County about the regulations, we had to bring a provider in that particular conversation. I think Madam Wilkista can't remember, because her speech and her speaking about herself really influenced some of the decisions that are being made on the registration part of it. You remember the registration was, 10,000 shillings. We came down because they could not afford that money, and she was able to speak for herself. We are waiting for one person. We want to count from 5. Disciples, are we there? All of us, we want to count from 5, 4, 3, 2, 1. At the 1 mark, she will cut that particular ribbon. We'll have some flowers, we'll have some pomp, and then we'll have some photo session. So let's start counting. 5, 4, 3, 2, 1. Woo! Woo! This has been launched officially. It has been launched officially as a public document to show that data really works. And this data is now available for all of us to read, to digest, to share. Thank you very much. So now we can stand for the photos. Now we can stand for the photos. So we will be having a larger photo session also outside or another corner after lunch. Let's settle. Oh, sorry, we forgot that. So we want to hear from just some closing remarks from the CEO, like what is the next chapter?
Thank you very much. Thank you for launching this with us. We are truly grateful for the partnership we've had from each one of you in this room and many others who are not here. Right now, we're in the process of passing around the dashboard. So the dashboard that, with the data that Cindy was presenting, is available on our website through the QR code that has been circulated. So you can actually go and access it. It's interactive. You can actually, drill down to the level of the sub-county, and just various disaggregations. So please, use that data. Our goal at the end of the day is that actually these dashboards will be owned by government. A lot of the data will actually be in the hands of government. So even as you're making decisions, Director Gatti, that actually this will be information that you have. I can actually see how many providers are in which part, where is there least support, what are the gaps maybe in Garissa versus Bungoma, as we provide support. Anyways, I don't want to talk a lot. I just want to, I think that the QR code will also be shared here in case you don't have access to the card. You can scan it and then you'll be able to receive it. It's also on the back of the report that we've just launched, the QR code here, so feel free to use it. We will be sharing a soft copy of the report. I think we have all your emails. We'll be sharing soft copies of the report later. But I just wanted to actually just call us to just, get us to, if possible, just think about 3 things. 1, data. And I'm calling on us as the ambassadors for home-based childcare to collect, share or avail and use data to inform policy and programming, as well as to track performance on processes, access, qualities and even outcomes of children in this setting, so that actually we are seeing what are we achieving. So data can actually help inform our programs. It can tell us what's working and what isn't. So I want to call on all of us to avail and share that data, and as we are sharing it, then together we'll be able to advance the home-based childcare agenda and really, the outcomes for our children and families. 2, my second point is let's recognize, value, and enable providers who provide this critical service. So, as the director representing the PS talked about, we talked about enabling and not being just enforcing. So, non-punitive and enablement of our providers. So that because they are delivering a critical public service, a critical service which is a public good. So let's enable these guys who are actually providing critical economic and social infrastructure for our country. And thirdly, let's allocate resources. As we saw, they're actually shouldering this huge development, national development priority on their backs and on their wallets. Truly, we can say they are subsidizing childcare for our nation. So I'm calling upon government to allocate resources, but also private players, whether philanthropy, the private sector, to provide cash or in-kind resources to support, home-based childcare providers. So subsidies from government, in-kind support. Remember, they are providing a public good that is critical for our national development. So data, recognition, resources. Thank you very much.
Julie, please.
Good afternoon. I'm Julie Wangoi, Programs Associate at NurtureFirst. And now we've come to our Q&A session and feedback. I'm sure from morning we've taken in a lot of data from the panel, and now we know probably you are noting down questions, but we have also shared these cards for your reflections with some guidance to share with us, and our team will be on standby to respond. So any questions? And comments too. And as the questions are coming in, with the QR code at the back, you can have a look at the public dashboards. As you can see, you're able to filter through the county level, sub-county level, ward level, and also across gender. So feel free, as the questions are coming in, to have a look at the data, and if any questions also comes up from there, it's welcome.
Yeah, thank you very much for the opportunity. So for me is a comment, and I think Madam Kashiri has already alluded to that. So for the paid childcare, which HPCC is part of it, one of the biggest challenges is who is the custodian of the data. For me, coming from, I was working in a health sector. Of course, NGO-led, but health sector. But one of the things that I borrowed from there was the fact that government is the custodian of the health data. So for us to really make sure that our paid childcare sector is formalized, so we need to make sure that the data, because our data is fragmented. Many people are collecting a lot of information, but then there is no effort to bring this data together and make sure that it is owned by the government. But I'm very happy with what NurtureFirst has done. The fact that Madam Agasheri has already said that the effort is now to make sure that the data is, the custodian of this data is government, so that it is accessible to different people, but also it is mainstreamed, so that as we try to formalize the sector, we make sure that the piece, which is very important, the data is not being left behind. Thank you.
Thank you very much, Mr. Felix. I think we have Director Wilkista.
Okay, thank you so much, Julie, for this opportunity. I also have a comment from the data that have just been presented on issues of special needs children. We've just realized that we have 372 children with special needs. But out of this data, you'll only find that only 2% of these children are enrolled in HPCC. But when we are also looking at the training needs, you find that when it comes to special needs, it was the lowest. That is at 32%. So what we need to think about is we need to focus on special needs. That is the reason why you'll find that, like for us who are in education sector, you'll find that these children who are in special needs children, they usually enroll at later age. You find that a child who is 10 years, that is when a child is being enrolled in ECD. Why is it? It's because of interventions are not done at the earliest years. So I think it's very, very important, as much as we are focusing on training on nutrition or or other aspect that that information was got from the ground, we also need to think about the special needs for the purpose of inclusivity. Thank you.
Thank you very much, Director Wilkista. Any other question, comment? Or maybe we should prompt people just to get your thoughts. I'll go to the team from the UON, Women Economic Empowerment Hub. Any thoughts?
Okay, thank you, Julie. I think I just want to concur with what my colleague said about data. KNBS have a provision for citizen-generated data, which is like data produced like outside of what they do. So I think, so what you have to do is just like what you have said, it has to like make the data to make its way into like the mainstream system. So I think it's a good opportunity like where you can have the data, although there's like a series of checks, they need to like do a series of checks, you know, from the methodology, all the processes to determine that it actually meets a certain threshold to be actually taken up into the mainstream system of KNBS. But I think they are an important partner, even as we, especially as we speak about data. I think the other, perhaps a question that I wanted to ask, we do, as the Women's Economic Empowerment Hub, we design, test, and upscale models, but from the perspective of more of like economic empowerment of women, traders in the market, that's our focus. So I wanted, and I think I had a mention of asking how you are asking the women about the price point or something like that, how they price their services. And so I just wanted to ask, I know from the needs assessment, perhaps when you are asking about their needs on the training, perhaps was there anything entrepreneurial that came out, perhaps maybe like a need on being like taught how to like price for the services, or, you know, like how to conduct, because that is a I know kidogo like focus on the entrepreneurial nature of the services. So perhaps did anything come out from the needs assessment in terms of entrepreneurship, like in terms of pricing for the services, or perhaps being trained on how to like carry out the services in terms of and all those things. So I think I would love to hear that. Thank you.
Thank you, Rachel. Maybe we can answer to that question. Cindy will take the question.
Okay. Thank you, Rachel, for that question. So I can respond to that, and then I think Felix raised a very interesting point on who's the custodian of data. So I'll hand over to Madam Gatti from NCCS to respond to that, and I can also speak on KNBS. So just to concur with you, KNBS, I completely agree. We have already begun discussions with KNBS about how they can utilize this data, as you say, as citizen-generated data. Further, we really hope with them to be able to include childcare modules into the other national national surveys that they do, the Kenya Continuing Household Development Survey and others as well, so that we can begin to institutionalize the collection of data related to childcare and obstacles or barriers for women being able to participate in the labor force. Right now, there's only one indicator in all the surveys that talks about childcare, so we're excited to be able to advance the discussion with KNBS. I was also reminded here by the director sitting next to me that that's an important discussion, so we are excited to be discussing with them already. On the issue of the financial literacy or entrepreneurship training, the data, we were able to collect data on those providers who have accessed any form of entrepreneurship or financial literacy training. It was only 1%. In terms of the demand specifically for entrepreneurship training, we're somewhere around 30% on average across the counties, yes. So it's what we've actually been advancing in the last quarter through Village Savings and Loan Association trainings targeting networks as one way of strengthening financial sustainability of providers and part of the financial inclusion pillar of the work. But yes, we have more detailed data on that and how that's disaggregated if that's of interest to you. It's also on the dashboard, so you can also look there. So thank you. Maybe I'll hand over to Director Gatti to respond on the question on the custodian of data. Okay. Oh, you have? Okay. Thanks.
So thank you so much. And my friend there, you rightly said that government is the custodian of this data. And we appreciate the fact that we have a lot of data, fragmented data, bits and pieces, each person doing their own stuff. But I want to confirm that government is in the process of harmonizing all that data so that then it becomes into one harmonized. We are developing a tool that will help us harmonize all the data that will then help us even make informed decisions. Remember that Kenya has subscribed to some of these regional and international treaties. The African Charter on the Rights and Welfare of the Child and the United Nations or the Convention, the UNCRC. So we require this data to also report on how we, as a government, are contributing to the promotion and protection of the rights of our children. So we'll be reaching out and working with the KNBS and other organizations that have all these data to just get to understand what it will look like, so that then at a click of a button, surely one is able to access this data, and so that it helps us to make decisions to support our children. And one thing that I picked in the morning, allow me to just take us back. The fact that you said 99% of HBCC providers are not registered. For me, that is really a wake-up call to government, because you can imagine if something happens to these children that are within, we are not saying that our care providers are bad, but things happen. What will become of those children? So it's a wake-up call for us. I think I have nilisikia nywele inasimama. And so we'll have to work together to ensure that they are recognized, as the CEO says, and so that they are supported. They are providing a very, very critical role. I want to echo Daktari's sentiments that the first 1,000 years, really, the first 1,000 days, sorry about that, the first 1,000 days of a person's early years really determines what that child becomes in the future. And you can agree with me that the challenges that we are facing in Kenya right now, when you look back, hatukupata that care during that 1,000 days during our upbringing. So because we have this information, let us try to really change our children and ensure that we are supporting our children to not only develop, but also thrive. So thank you so much. We've picked a lot from this, and we'll be working with you and many other partners to ensure that we are implementing, what we have received from here. And thank you all for all the good work that you do to support our children. Thank you.
Thank you very much, Director Gatti. Karongari?
Oh, okay, you remember my name. Hi, my name is Karongari Washir from Tiny Totos. We're a social enterprise that works in the childcare sector as well. And I just had a question which you may have addressed earlier in the morning, but I was a little late, so I'm not sure. But you said that you defined HBCCs as caregivers who are, let's say, serving 6 children or less in their homes. Is that correct? Cindy? No? Yeah, because I wanted to find out, for us, the daycares that we work with, on average, they serve 17 children or more in their homes. And that would require different standards and regulations, considering the size of their homes, if you will, because most of the women that we work with are in the slums of Nairobi and its environs. So I just wanted to be clear on how we're defining home-based childcare centers. Is that HBCCs? Yeah.
Cindy?
Yeah, thanks for that, Karangari. So we define home-based childcare as children being cared for in the home of the provider, and it's a non-familial caregiver. The mapping revealed the providers who care for 1 children all the way to providers who are caring for 30 plus, 40, 50. However, the six number that you're referencing is that from the data we found that 83% of providers are caring for 6 children and less. So it's fewer than 6 children and fewer. So in some counties, particularly in Murang'a, where there's a lot more open space, you find providers with a lot more children, parts of Kisumu as well. But the majority are, 1 child to 6 children. And actually, it's on, is it median or mode, where it's 3? The mode is 3. 1 provider to 3 children. Sorry, he's a statistics guy. Yeah, I communicate that. So, but again, the dashboard has all of that broken down, even to ward level, as well. So, yeah, another one.
Okay. Then I guess my follow-up question is: even though the interest is not necessarily in financial literacy, we know that you need to have more children in order for you to then become financially sustainable. So I guess I'm sort of pushing the agenda here for the women's economic empowerment piece and the financial literacy, because in order for them to continue to do this great work that they're doing, they need to be sustainable, they need to be profitable, and no offense to government, but we might not have the subsidies for them in the next couple of years. So my thought would be to empower them to remain or to become financially profitable so that they can continue to provide this amazing service that they do provide.
Thank you so much. I think NurtureFirst, as NurtureFirst, we completely agree with that. And there needs to be funding unlocked at a system level, and I think there are efforts already ongoing on how to figure out the subsidies into policies and budgets, but there's also work to be done at a provider level. And for those who are able to care for more children to make it a viable enterprise, then they should be supported to do so. So financial literacy and financial inclusion is also a core aspect. So it's got to be both, and I think that's why there's space for all of us in the sector to have different models going on to support the providers. I think Dr. Monica had a question, and then Joanne.
Thank you. I think it's a comment and a question at the same time. I believe home-based care centers, this is part of community strategy. So my question is, and this links with your concern, you know, sometimes as a health provider, you start having goosebumps because in case of anything in the facility, in your center, are we linked to the nearer facility? Do we have a relationship with the link facility? Because this is a level 2, level 1. Community strategy is level 1 of health system in Kenya. And level 1 is supposed to link formally with level 2, level 3, whether it's private or public in case of anything. Because emergencies occur. We are lucky that nothing has happened. I hope nothing has happened. If we didn't report, we believe nothing has happened. But even as a mother at home, you know something can happen. So my big question is whether we have some formal linkage with the nearer facility so that you are not accused of negligence or something. I would really recommend, if it's not there already, that we formalize that relationship with the link facility in the community where you are. Level 1, level 2, public, faith-based, so that you are recognized and they can support you in case of emergency. Thank you.
Thank you very much, Dr. Monica. I think Cindy will speak to that on some of the linkages that we do under L1.
Yeah, I can actually invite Abdallah, who can also speak to this. The guidelines that were developed in Mombasa County, there is a component of, as part of the minimum guidelines, that providers should be linked to CHPs. But Abdallah will know more.
Thank you for raising that. And for Mombasa County, that's something that has been incorporated in the HBCC guidelines that have been developed. Yeah, we felt that for the HBCC providers that we are working with, yes, they are recognized, but maybe they are recognized at their service point where they are offering these services. But when it comes to the health sector, they are not recognized. So we felt that since we already have a system in place, instead of reinventing the wheel, we just ensure that there is a close partnership between the HBCC providers and our community health promoters. Because for community strategy, you find that the households that the HBCC providers that we mapped, actually there are some households for our CHPs. Yeah. The only difference is that we do have children during the day, and in the evening they go back to their actual households. Yeah. So they are part and parcel of community strategy, and that linkage is there. Yeah. And for Mombasa County, I can talk about primary care networks. And as a country, this is something that we are all embracing it. Yeah, for Mombasa County, majority of our facilities are private, but our community health promoters, from the previous policies, we found that they are linked to public facilities. So for now, we are working closely with the private sector in the spirit of primary care networks, such that at any given point, a child can be referred to any private facility, provided that it's a level 2 and a level 3. If the parent has a SHA, I think we are working towards that in ensuring that any child can be referred to any private facility or any public facility, and he can get assistance. And also our community health promoters, we also ensure that our community health promoters are linked to these private facilities, so that at any given time, community health promoter hears of an incident,
he or she can escort the mama mlezi to the nearest facility and the case can be sorted out. So that's part of the guidelines we are coming up with in Mombasa. And I think once everything is done, we'll see now how the implementation, yeah.
Thank you very much, Abdallah. I think I wanted to add to that, though I think the answer was truly comprehensive. I think Cindy, when she was presenting, talked about mapping not just the providers but also the services that are near them. And one of the things that we are doing through that service is to actually link them to available services. So, for instance, to the health facility, I think Alistair talked about being able to actually link to them there for vaccination. But also, I remember when we were in Kisumu in September, they actually told us about the way they know how to even, if there's an emergency, one of the providers was telling us, if it's something that can wait for the parents, they call the parents to come and take care of the child. But if a child is sick, they're actually able to take them to the dispensary. So those linkages are there. They need to be strengthened, but they are there. But I think one thing I wanted to just mention is that we are also trying to ensure that they have linkages to the chief, to report children who have been abandoned, because you have people who are leaving their children for weeks in the care of, mama walezi. Yeah, people are leaving them there for weeks. So you become, I don't know, another mom. So linking to children's service. So one of the things that, and I think maybe one of the things that maybe as you investigate in the dashboard is what are those services that they've been linked with, and one of the things we are tracking is which ones are they using. And I think maybe as we see what the demand is, we'll be able to craft services, maybe more meetings with even the specific services that they need. In Mombasa, one of our providers was actually able to link to children with disabilities. I think we were there last week and they're telling us about they're able to identify children with disabilities, link them to the Mombasa, the National Council of People with Disabilities, also link them there for services, but also link them to people who could provide wheelchairs and so on. So really, I think what we are doing is ensuring that this person is not alone. They are a frontline service provider, but they are also an extremely essential resource for us as a government and as a society. When you think they're identifying, they're doing a lot of the linkages and the referrals. Another provider we saw last week in Mombasa was telling us, children coming to us, some of them have difficulty walking. She said, this child needs to be taken to Coast General. So they're actually identifying these things. They may not know what exactly the diagnosis is, but they're seeing there's a developmental need here. So, they already know where the person needs to go. Of course, they're not the ones who are going to take them. The parent needs to. But you can actually see there are an extremely essential linkages between the systems that we, as government, have visibility into, whether health, education, etc., disability services, etc., and the community. They're identifying, they're linking. Thank you.
Thank you very much, Dr. Gasheri. We have a question here. Jared?
Maybe if I may proceed. From the dashboard there's a section on services, okay? So we were able to map all the services which we felt provider might really require. And the next phase for this dashboard is to ensure that all the partners who are providing these services are able to access the dashboard and also be able to access the database for all the providers. So that at any point, a provider can be able to request for the service directly. And among the service providers, they can be able to take the request and act on it and report it back. That's where we want to be, because if we're able to ensure that all the requests and all the services provided are in one-stop shop here, we'll be able to look at the service uptake, response time, and then be able to see what are other services which you can be able to provide to the HBCC providers. So in the next, I think 6 months, when you come back to the dashboard, you'll realize that a lot has really changed. And in our intervention, number one, learning intervention 1, where we talk about recognition, the whole idea is we really want to ensure that we improve the linkages and ensure that not only the health services, but even the financial literacy which we are talking about, there's a partner who is willing and available to provide that. Yeah, so just look out for some improvement on the dashboard and the system. Thank you.
Thank you, Jared. A question from Michelle.
Actually, it's more of a comment. When we look at the key findings, I just want to highlight to colleagues and my sisters also at NCCS the finding of long-term care and the concerns I know that we had in Moronga, for example, that these could end up being de facto CCIs. And as we're going through care reform, I think, and as we continue to develop standards, we need to keep this in the forefront, that as we register, as we recognize, which we must do, that this doesn't become de facto recognition of overnight care and turn HBCCs, which are far many more than CCIs. We see we have 13, for example, CCIs in Moronga, yet we have over 2,000 HBCCs. So I just want to flag to colleagues that this is something that can be a slippery slope if we are not very careful. So thank you.
Thank you very much, Michelle. Any?
Sita, good morning or good afternoon. Let me start. My name is Mutisia Muindi, Deputy Director, Gender. I want to thank NurtureFirst, for the good work they are doing. Data does not lie. But there is one interesting data is getting worrying to my side. The women are not interested. The providers are not interested in doing entrepreneurship. Do you do it for free, social, for entertainment? Well, it is a good service that we are bringing on board to our children. But we should have the entrepreneurial mind. Because it's actually, social entrepreneurship is also actually, you are not after making money. You are after making transformation to people. But at the same time, you also need to continue offering the same service. How do you do it if you don't want to be trained on how to remain there? That's a question for the providers. Now, I want now to say something to link this information with the care policy I talked about in the morning. In one of the key issues in the policy that is actually at advanced stage, I think your CEO has been part of that journey, is on care for the children below 4 years, where you are actually doing the business. Our statistics that we were able to gather, that area is not as good as we are talking about. There are people who do it, wengine wanapatianga watoto aspirin so that they can sleep, isn't it? Is it good for our children? So what we are simply saying is, the care is saying that those services require to be regulated, registered, at the same time being recognized as a caregiving service. Sawa? Are we talking? So those who have not interacted with that document, don't read it or the whole document. Look for that area, because that is your area of interest, and see what the government is proposing to do. We are also proposing you to be trained on many things. Many things, not hiyo tu kidogo mnasema financial literacy. Mnatakiwa kufunzwa maneno mingi ya kutengeneza, kuchunga watoto at that tender age. Because that is very key. That is where we either lose or gain them, isn't it? So it is a very important stage, and actually the government is recognizing that there is need for that. There is need for us to recognize and value the work that you are doing there as work. At the same time, you are women. Our interest as our mandate as a State Department, we want you to be empowered, isn't it? Sini kweli, nataka tuseme kweli ama si kweli. So it's also good for you to be empowered and then give us the what? The services. Nilisikia mmoja alikuwa mwalimu. Kwa nini aliacha kufunza watoto wengine wakuja kwa wadogo? What was the calling? I used also to be a teacher. I know there's a lot of calling teaching. Yes, teachers like doing free work. This is a calling. When you hear a service, a calling, ni kujitolea ama kujituma to go and offer services almost for free, not for money. But you require to remain, isn't it? And grow at least. Si ni kweli? Therefore, you require that knowledge for your empowerment and for the community empowerment. So kindly think, and we should now, the data is telling us you don't require, but I'm saying that data should be reversed and show that you require that. Thank you so much.
Thank you very much, Mr. Mutisia. I'll welcome Dan to just share a few insights on the financial inclusion, as you also welcome, we make the closing remarks. For further feedback, there is an email at the back of the card, general@nurturefirst.org. For any feedback, questions, they are welcome. Thank you.
Thank you, Julie. You know, I've preached the whole day, so I didn't want to talk about financial inclusion. You put me on the spot. So financial inclusion, and your comment is very, very welcome. One of my biggest, I would say, conversations at NurtureFirst, and I'm the finance guy when it comes to that, is there cannot be any structural change without injection of finances. There cannot be much change in terms of quality without investment. It's at the center of this because it is happening in people's homes. So which subsidies are going to change people's homes? You understand that question? That is why as NurtureFirst you're very critical, and right now, actually the last quarter we've been thinking about how do we design a model to improve the financial well-being of providers. So we've started with VSLA groups, and they've done extremely well. We have a group in Kisumu that has just shared out, it was what, 150,000 Kenya shillings. And part of that investment is primarily going into their homes to build that quality we are talking about. Part of this element, and Douglas is here, we've done in Moranga also, we have an element called SWAP, saving with a purpose. We designed this so that within the VSLA element, with the incomes they're getting, they're able to purposefully save some money to improve the service they are providing. So it is not that we have not done a talk about, it's only that we felt that that should come not as the primary focus. All right? The primary focus should be quality. Then the second focus, quality with money, improves everything. So that is why we are working on it very critically. There is feedback about the financial inclusion training right now. We are designing that particular manual, and we continually support our providers to ensure that they're able to improve, first of all, their financial knowledge. Second of all, how to turn and support themselves from the enterprise they're doing. So, Mr. Director, your comments are home, and we're going to work extremely hard on that. Back to my disciple role. Now tumewacha kizungu mingi. I want to close out this particular conversation and really appreciate, on my behalf, the providers. Let us give a clap again. Looking after children is very hard. I know from experience, because I'm a parent. And as being a parent, my wife, I respect her for one thing. Just one thing only that I respect. Akisema tu hiyo, anything else changes, is the efforts in looking after the children. Most men do not see that. Myself, even everything actually is controlled by that, because when I go Ushago, like now, Christmas, so mmeongeza watoto wangapi? Kichwa yangu inarudi kwa reset. Kwa sababu I see the effort and the work that it takes to raise a child. If it takes that effort to raise my own child, what of these people who are raising other people's children? In Mombasa, and I've been in Mombasa several times, especially Mombasa where we have the tourism economy, children are being left months old in other people's care. In Kisumu, again, we have gone to other places in Obunga, in Banyata, and in the slums, where we have providers who have disappeared after leaving their children. So this conversation is very dire and critical, both at the systemic level, as Cindy said, but also at the level of implementation. The realities on the ground. So we have to be very, very targeted on the realities that are happening on the ground. Tunaweza sema kizungu mingi at this board level, but the reality on the ground must dictate how we design our programs. And with all that, kenye mebaki ni sadaka mtatoa, but before that, I want to welcome Madam Wilkista. Karibu sana for the closing remarks. Thank you so much, everyone.
Thank you so much, Dan. And you've talked about the reality on the ground, and which is the most important thing. I want to take this opportunity to say a big thank you for each and every person that is here because of the time that you've taken, your commitment, and your thoughtful contribution towards this forum. This forum has given us a lot of information that is going to help us to do some interventions that are going to be this intervention will target both the child and the caregivers. Many times we forget about the caregivers. As we focus on the child, we forget about the service providers. And these are the most important people. You know, if their well-being is not taken care of, then it means that this child is also at risk. So our service provider, you are the most important people in this forum. And let us give them a better clap than that. I always said that when we focus on the very, very young, 0 to 3 years, then the future is bright. We need to come together as partners, as county and community level, to ensure that collaboratively we focus on raising the health of these young children. So as we leave this place, remember the data that we've just received is just from 3 counties. If 3 counties can give us such kind of a data, what about the whole country? Then it means that we have a lot. We don't need to sleep when it comes to matter of children. We need to wake up. And it has always been said that when it comes to home-based childcare or childcare welfare, it's mostly female-dominated. We are also urging our male counterparts, kindly, our male counterparts. We want to see you coming and taking care of, helping us to take care of these children. I like there's one of our male provider in Kisumu. When I see him, I feel motivated. Because to make it even worse, that he cares for the special category, which is very difficult. You go to this childcare facility, you only find one who is special or 2 or none. Why? Because people fear. They don't have the skill to handle the special category. And we are talking of inclusivity. So we need to work on that direction to ensure that all children, irrespective of where they are coming from, they are being taken care of, and we are going to have a brighter future. Otherwise, I want to thank you so much. When you go back to your homes and places and people who travel as far as Mombasa and Kisumu, I wish you journey mercies and may God bless you. Thank you. And I close it officially.
Ladies and gentlemen, we have come to the end. And now it is time for somebody to pray for the manna. Who will pray for the manna? And then we go. There is a pastor. Oh, I forgot the person who gave us Jesus. This is here. Oh, male participation.
Thank you so much. Let us pray. Baba, katika jina la Yesu, tunakushukuru, tunakutukuza. Asante ni kwa sababu ya neema na fadhili zako adhuhuri ya leo Bwana. Tunakushukuru ni kwa sababu ya kutupa nafasi kushangia watoto, na watoto ni wanadamu. Neno lako linatuambia ya kwamba kati ya vitu vyote ambavyo ulivyoumba ulimpenda mwanadamu sana. Asante kwa sababu ya Yesu ambaye alituonyesha mfano mwema, na kwa sababu tunataka kumuiga, in one way or the other tumesema hata sisi watoto waje kwetu. Na tunakushukuru kwa sababu ya kutupatia hiyo nafasi ya kushughulikia hawa watoto. Naomba ukatusaidie yote yaliye hapa, providers walio manyumbani, ya kwamba Bwana utatulinda na utatukinga na utatuhifadhi tunaposhughulikia hii sekta ya watoto. Asante ni kwa sababu utatupa hekima, utatupa maarifa, utatupa nguvu, na hata utatupa fedha ambazo zitatuwezesha kusongesha haya mambo yote mbele. Tunakushukuru kwa yale ambayo yamepangwa Tunakushukuru kwa yale ambayo yamefanyika na tunakushukuru kwa yale ambayo yatakayofanyika. Tunakushukuru kwa sababu tunajua utatuwezesha, ni kwa sababu tuko katika agenda yako ya watoto. Asante kwa sababu ya wote ambao wamenena mahala hapa. Tunapofungukana, hata tunapoenda kula chakula cha mchana, tunaomba nguvu, tunaomba hekima, tunaomba ulinzi wako barabarani. Tukifika manyumbani, tutakushukuru na tukutukuza. Na ni katika jina la Yesu Kristo tunaomba na hata kuamini. Amen.
Hello, hello.